All right, do we want to wait anymore or go ahead and get started? I think we can probably get started if we want. This first little bit is just a little kind of introduction, some housekeeping stuff. So thanks everyone for joining. I'm Dr. Matthew Manring, one of our retina doctors over at the Eye Care Center. So it's a good Sunday morning, and thanks for joining us to do a little education here. So we'll do some introductions and go from there. So we don't have any financial disclosures for this presentation. We do have a grant from Glaukos for today's event. I want to just also take some time to say thank you to Priscilla for helping put this event together so that we can talk to you and can make sure that you guys get your hours and do some teaching and talk about what's new in the world of eye care. You guys should have hopefully gotten an email with a little Starbucks gift card for today's presentation. Since we aren't meeting in person, just a thank you for coming, and hopefully you can have a little coffee and breakfast in order to enjoy this. We're going to be doing 4 presentations this morning. Dr. Kanoff's going to talk about retinal imaging. Dr. Parikh will be talking about optic neuropathies. Dr. Noble will talk about how the retina plays into cataract surgery, and I'll talk about some new medical treatments for retina diseases. If there are any questions, you can put those in the Q&A, and we'll be moderating those, and we'll look to answer some questions. We'll have some time at the end of each presentation to do some questions as well, and you can use the chat function as well. We will definitely have the QR codes for you, and we'll try to show those a few times just to make sure that you guys get your credit. And then you should also have a feedback form for us if you can work to complete. That way we can know how well we did. And if you have any ideas for future presentations, we usually try to figure out how to accommodate those. So as you're well familiar, we are both clinic plus the ability to do surgery at our surgery center just across the parking lot in Longmont. Recent endeavor starting last year was the Advanced Vision Research Institute, where we are conducting some clinical trials. We'll be talking about some of those new and cutting edge treatments that we can help deliver for patients at our office. We do have a little update, as Dr. Benedict has now officially retired and is enjoying retirement, skiing and biking and traveling all over. Dr. Noble joined us towards the end of last year. We still have 4 retina doctors and are continuing to see from that. Our glaucoma and cataract team remains, as well as Dr. Myers and Dr. Werner. We have our optometrists, and Dr. Bartlett just joined us earlier this year. So he's been in Colorado since 2018. And just joined our practice, so we welcome him as well. Our surgery center, as we discussed, our ability to do lasers and surgery conveniently for patients right near the Longmont office. We do also have offices in Boulder, Lafayette, and Greeley that we will go to. When trying to get us patients, obviously we have our phone number, and we try to expedite calls that come in from other healthcare providers with a more dedicated option. Nights and weekends, a lot of you have our cell phone numbers. We're usually pretty happy to get that to you if you have any issues. So if you have any need for that, I think Priscilla can get that information to you. And then on our website, there are forms available for non-urgent and routine referrals if you want to do it this way. There's a patient referral form, and you have the ability to upload a copy of the chart and any images if you want. I know a lot of times, sometimes our referring doctors will sometimes email us images for review as well too. So at this point, we'll go ahead and get started with our presentation. So I'm going to go ahead and let Dr. Kanoff get ready to start his presentation. We'll have the QR code during a question and answers afterwards for each presentation as well. So don't feel like you need to rush for that right now. We'll have that up afterwards too. So.
Thanks, Matt. Appreciate that introduction. Let me just get my screen shared here. All right, let's see. Okay, good morning. Well, I appreciate everybody joining us on this Sunday morning. So I wanted to do a update and just a reminder about retinal imaging. In terms of our retinal exam and interpretation and treatment of the retina, we're lucky that we have a lot of different imaging modalities to really help us. And there's been a really rapid progression and proliferation of different ways to image the retina. And each time we get a new image modality, it really adds to our ability to understand disease, treat disease, and to follow how our treatments are doing. So I just wanted to walk through a couple of the different image modalities that we have. Some I'll spend a little less time on, some we'll spend a little more time on, because I think it'll be a little more helpful for you guys in your offices. Okay. So one of the first image modalities that everybody is very familiar with is just the good old fundus photography. And, it's one of the first imaging modalities that came into use in clinical practice. We've been using it for extremely long time, has a lot of benefits, really good longitudinal data. So, we can write down the best description of the retina possible in our note, but obviously a picture is worth 1,000 words. And in terms of following the size of lesions or following location of hemorrhages or progression, there's just really no substitute for a fundus photography. It's also readily available and available in pretty much almost all of your offices, and is going to give us that good comparison. So there's two different image modalities for fundus photography. There's really the traditional narrow angle fundus photography, which is what was available over the long period. And this was obviously a great advancement from not having any imaging, but as now we understand, wide angle imaging has been a little bit limiting. And really, most of our imaging has now switched into the wide field. You get the benefit of being able to see about 200 degrees of the retina, and there's really no limitation, because with the high resolution, you can zoom in and get a really good view of the macula or of the fovea as well. And then I just like this photo from Optos. This is a patient who really has a lot of problems going on with their eye, and it's hard to know where to begin the treatment. So I'm not going to talk a whole lot on fundus photography, because I think it's something everybody is pretty familiar with and pretty familiar with the interpretation. So complementing fundus photography is really a fluorescein angiogram, which is something we use in clinical practice a lot. And so fluorescein angiogram is based on the principle of luminescence, which is essentially energy from the electromagnetic spectrum. So any type of light is absorbed at one frequency, and then it's re-emitted at another frequency. So essentially the fluorescein molecule, as it's stimulated with light at approximately between 465 and 490 nanometers, the electrons in the molecule are pumped up to a higher energy state. And then as those electrons decay, then they emit light at a different wavelength at this 520 to 530 nanometers. And that's essentially how a fluorescein angiogram works. So it's a camera with a flash, which is able to flash at a specific wavelength, and then through the use of filters, able to receive the information at a different wavelength. And so fluorescein is injected into the vein. And so this part's really important for how we're able to interpret it. 80% of the fluorescein is bound to proteins, and about 20% is unbound, and that's the part that remains available for excitation and allows us to visualize the fluorescein. And so one of the key sort of abilities of sort of interpreting this is that normal retinal blood vessels are impermeable to fluorescein leakage. So essentially, fluorescein will flow through the normal retinal vessels without leaking into the retina. So therefore, when we see fluorescein outside of the retinal vessels, we know that there's an abnormality, and that's basically how we interpret it. So this is just a series. This is just a series of some complicated slides, and really the details are not as critical, but it sort of breaks down initially how we think about interpreting a fluorescein angiogram. And so initially, you think about a fluorescein angiogram in two broad categories. One is there decreased fluorescence, so hypofluorescence? So essentially, are we seeing less luminescence than we normally would? And then that's basically divided into two different categories. We could be seeing less of the fluorescein because something is blocking it, or we could be seeing less of the fluorescein because essentially it's not traveling to the retina through some type of vascular filling defect. And then also we then do the same when there's too much. So essentially, if there's hyperfluorescence, is that because there's leakage? Is it early leakage or is it late leakage? And then essentially, where is that leakage coming from? Why is there too much staining? And then again, we use that to break down and interpret what's going on with the retina. So this is just an example of one of those broad categories on a fluorescein angiogram of where we're not seeing enough fluorescence. So obviously on this picture over here on the right side of the screen, there's a hypofluorescence. So we're not seeing the normal retinal vessels, and it's because something is blocking it. And you can see from the color photo that there's blood blocking it. So again, so that's one broad category of what we're seeing. So this is a similar, this is another one of those broad categories of hypofluorescence. So you can see here, this retinal blood vessel in this quadrant, there's no fluorescein in there. So that's an example of a blockage. And as you can see from the color photo, it's a branch retinal artery occlusion, and you can see where the occluded vessel is, and then there's not enough fluorescein flowing in there. And then this is just sort of an example of one of the other side where there's too much fluorescence. So we can start seeing here, pretty early after the injection that there's a little area of accumulation of fluorescein. And then we can see as the time from the injection gets longer, we see more fluorescein. And then you can see it start to get these indistinct borders. And so that's an example of where fluorescein is outside of a normal retinal vessel. And then that helps us interpret what's going on. And then here, this is an example of a choroidal neovascular membrane. So fluorescein angiogram is an extremely helpful modality. And I think sometimes we don't get enough fluoresceins that especially with macular degeneration or a branch retinal vein or a central retinal vein occlusion. It's very, it's straightforward to see with the examination, the color fundus photo, and with the OCT, we know there's a branch retinal vein occlusion. We know there's cystoid macular edema. We know we're going to treat it with an anti-VEGF. So what's the point in getting a fluorescein? Well, I think the fluorescein in those instances could be really helpful to say, well, how large is the area of non-perfusion? Is it really ischemic, or is it not particularly ischemic? And that's really helpful, I think, for knowing, helping to predict what's going to happen in the future. So I still do a lot of fluoresceins at the initial time of diagnosis, because I do think they're very helpful in prognosis and knowing what I need to watch out for. So example of that retinal vein occlusion, if I see there's a whole entire quadrant of the retina that essentially has no perfusion, over time, I'm going to be really closely observing that patient for the development of neovascularization. Whereas if the fluorescein shows that there's just a very small area and there still is relatively good perfusion, then I'll be less worried about neovascularization developing. So what the fluorescein is not great for is the fluorescein is not great for assessing the choroidal vasculature. And essentially the reason why is, if we think back to the anatomy of the choroid, as the blood vessels come into the choroid and they get smaller and smaller and turn into the the choriocapillaris actually has fairly loose junctions, and there's a lot of blood and other parts that can sort of leak out through the choriocapillaris, which is a normal part of how blood flows through the retina. So essentially, fluorescein also leaks out of the choriocapillaris, and that's why you just get this sort of very bright background of what we call the choroidal fluorescence. So not great for seeing the vasculature. But on the other hand, a different molecule called IC green, indocyan green, it has a very high molecular weight, and it's 98% bound to proteins, meaning that it's not going to leak out of the fenestrations in the choroidal blood vessels, which is why we're going to be able to see the choroidal vasculature. And so here's an example of just a normal IC green angiogram, and you can see that we can see the normal retinal blood vessels that we see with the fluorescein angiogram, but now we can get all of these great details of the choroidal vasculature that really is extremely difficult to see with a fluorescein angiogram. So a couple examples of where an IC green is helpful. And again, I think this is a test that we actually don't get enough, especially in somebody maybe who's having a treatment-resistant case of wet macular degeneration. IC green is very good at showing us polypoidal choroidal vasculopathy, which is somewhat challenging to see on just a normal fluorescein or on an OCT. And so this is an example here of a IC green angiogram. And you can see right in the middle here, there are these polyps that are very characteristic of polypoidal choroidal vasculopathy. And then we can see over on the OCT, the corresponding to where these line scans are, is you can see these sort of large PEDs, which correspond to these polyps. But if you just got the OCT and you looked and you saw their subretinal fluid, you might think this is just a serous PED or maybe a hemorrhagic PVD, wouldn't necessarily know it was a polyp. And so this can really direct us towards, maybe pursuing PDT treatment in somebody who's having some resistance to anti-VEGF. This is just another more zoomed in view of somebody with a PCV, polypoidal choroidal vasculopathy. It can also be helpful in seeing blood vessels and other diseases. So this is an example of a choroidal melanoma. And on the fluorescein angiogram here on the right, it's really hard to make out where the blood vessels are, sort of what's happening. But over on the IC green, you can see that you can see the sort of dual flow that's typical of these choroidal melanomas. You can see some flow from the retinal vasculature and then a sort of a separate flow from the choroidal vasculature going into the choroidal melanoma. And then also in central serous, it can be helpful. This is sort of an example of just that classic smokestack in a fluorescein angiogram, versus in the IC green, you can see these sort of areas of a sort of filling defect and sort of bright areas. And maybe in this particular example, maybe it's not the best example of where an IC green can be helpful because it's pretty clear where the leak is. But especially in somebody who has a really large leak where it's hard to pinpoint exactly where it's coming from, or especially in somebody with chronic central serous, where on the fluorescein, you're going to see all of these bright spots just over the whole macula, and it's hard to tell what's active, what's not active. The IC green can be very helpful in knowing where to target treatment. Okay. So moving on to other imaging modalities is fundus autofluorescence. So essentially what this allows us to do is we're able to map the naturally and pathologically occurring fluorophores of the fundus. So essentially a fluorophore is a molecule which is able to absorb energy and then again emit in a different spectrum. So we're able to capture that. And by far the most common of these fluorophores in the fundus is going to be lipofuscin. And lipofuscin almost exclusively accumulates in the retinal pigment epithelial cells. And so this fundus autofluorescence is a great way to image and see what's going on with the RPE of the retina. And this is a normal fundus autofluorescence of what we typically see with a normal pattern. And then obviously, here, because sometimes this can look a little similar to a fluorescein angiogram, but obviously the big difference here is that instead of the blood vessels being bright with a fluorescein angiogram, they're dark because there's no lipofuscin in those blood vessels. Now there's a number of things that the fundus autofluorescence is very helpful for watching. One of them is geographic atrophy and dry macular degeneration. It really highlights very, very well exactly where the atrophy is occurring and where the loss of the RPE cells, and then very helpful for watching longitudinally over time. You can imagine between, if we had the corresponding color photos between this image and this image, just looking at the color fundus photo, it might not be extremely obvious that there's been progression. But when we look at the autofluorescence, it just becomes really obvious where progression is occurring. And the hope is as we get better treatments for geographic atrophy and dry macular degeneration, this is going to be extremely helpful in determining who's a good candidate for it and for monitoring the disease progression. And this is actually one of the key ways that we're looking for patients to be included in the trial that we're running right now, which is a trial for a therapy of geographic atrophy. And so one of their criteria is based on the size of the lesion on fundus autofluorescence, because it's just such a great way to image it. Okay. Now, up until this point, obviously we've talked about 4 different imaging modalities: color fundus, fluorescein angiogram, icy green angiogram, and then fundus autofluorescence. And you can imagine it would be difficult to take a patient around to 4 different cameras to get this all done. But one of the nice things with these imaging modalities now is these are actually all wrapped up into one camera. So our Optos camera is able to do all of these imaging modalities very close to the same time. So essentially the sequence when we sit patients down is we'll take color fundus photos, then we'll take autofluorescence, so that's very quick. And then the nice thing is that if a patient needs a fluorescein and an ICG, actually what we do is we take the 2 different dyes, we mix them in the same syringe, we inject that, and then the camera actually takes the icy green and the fluorescein angiogram at the same time. So with every click of the shutter, it essentially does a fluorescein, and then a tenth of a second later, it then does a separate icy green. And so you're getting those same frames, but it's not like the patient is sitting through a half an hour of imaging here. All of these images can be acquired, over the course of 5-6 minutes, which is essentially the time that you need to have the dye go through its phases. Okay. So OCT angiograms is a relatively new, non-invasive method of imaging the, I say macular vasculature here, but really as these OCT angiograms improve in both quality and the size of the scans, it's really going to turn into a modality for imaging the vasculature of the entire retina. So most of the cameras are limited to just doing, either the central, like a 4x4 millimeter or 6x6, or some of them are 8x8 millimeters, but over time, they're going to get bigger. And essentially, no one really understands the math of how OCT works. Maybe there's one person somewhere who really understands the math of it, but essentially, the way the OCTA is working is essentially taking 2 scans extremely fast and then comparing the difference between those scans. And if you compare the difference between one OCT scan and then a second OCT scan taken, a millisecond later, the retina, the retinal blood vessels, none of that will have moved. What will have moved is blood. So as blood flows through the retina, it moves. It'll create a slightly different image. And then through the magic of math and computers, they're able to then calculate where exactly those red blood cells are, and then give us a nice image like this. So, there's really a lot that we can image with OCTA. We can look at choroidal neovascular membranes, diabetes, both non-proliferative and proliferative, vein occlusions, MAC-TEL. And I think as the imaging modalities get better, higher resolution, less plagued by motion artifacts, this will get more and more useful over time. So this is an example of a patient who has wet macular degeneration. You can see there's hemorrhage, and then on the, there's hemorrhage, and then there's fluid on the OCT, and then outlined up here in yellow, you can see where the choroidal neovascular membrane is. And this might be a little easier to see here. So you can see actually this is what a choroidal neovascular membrane looks like on these OCTA. Now, there are some disadvantages. It's very plagued by motion artifact, because you can imagine if it's using a motion as small as the movement of a red blood cell over the course of a millisecond, if the patient's head's moving, that's going to confuse the scan. Now, this is, you try to compensate this based on software, and some of the machines are better than others. Any media opacity can degrade resolution. So, our OCTs now are remarkably good and efficient at being able to scan through vitreous hemorrhages and cataracts and cornea edema, and we can really get pretty good OCTs through a lot of media opacity. But OCTA has a hard time going through the media opacity. And then really, I think one of the big things is that, you can't actually see leak. All we're looking at here is flow. And, what I think we've figured out over time, especially in macular degeneration, is it's not uncommon to see a patient who has actually a choroidal neovascular membrane, but doesn't have actually true wet macular degeneration. One of the thoughts is that as the atrophy of the choriocapillaris and as the RPE happens in dry macular degeneration, these choroidal neovascular membranes actually could be a slight compensation to try to still deliver nutrients and blood to the overlying retina. And so really, we can't tell the difference on an OCTA, whether is this a choroidal neovascular membrane that's leaking, or is this just a choroidal neovascular membrane that's there sort of more incidentally. And so really, that's, you really need fluorescein to be able to see, is there leak happening? Is this causing trouble? And then, something that always has to be considered, we never want to think about it as the first thing, but, OCTAs are actually fairly expensive devices. And right now there's no way to bill for them. You can bill for an OCT, but there's no extra or separate code for an OCTA.
Dr. Canoff, I'm going to just jump in right here as Dr. Manry is just a comment. And I don't know if you agree with me or not. There's definitely some advantages to these, but just like you were saying, even if we don't see any fluid, if we identify one of these on a patient, it might be something where instead of seeing them every 6 months, we might say, okay, listen, you potentially have a CNVM here. Maybe we're going to watch you at a slightly shorter interval, perhaps see you back in 3 or 4 months and monitor a little bit more closely, knowing that they're at higher risk for wet macular degeneration. Do you agree?
Yeah, that's a great point. And just because, that'll definitely make me follow people a lot more closely. So I guess that would, under the advantage that, there's no reason to do a fluorescein on everybody who comes in with dry macular degeneration. That would be extremely overkill and not in the best interest of patients. But one of the nice things about the OCTA is it's non-invasive. It's the same as an OCT. There's no dye, there's no needle pricks, there's no risk. And so I think that's a great point, is that this does allow us to get one more piece of data. And I 100% agree. If I see a CNVM on a patient, but maybe there's no leakage, I will definitely see them. I will watch them a lot closer than I would just a regular garden variety dry patient. So, the fact that we can essentially do this in, maybe 20 seconds, 30 seconds, and there's no dye is just a huge advantage. And I think, when Dr. Benedict was giving this talk maybe 2 or 3 years ago, he made a comment that, OCTA is not ready for prime time, and, we don't really know what to do with it. But I think over these last couple of years, I feel like it really has been really become an important part of clinical practice, and is really, as we get better at interpreting these images and sort of get better at understanding what they mean, it's really become a great tool. So I think it would actually, just like maybe 15 years ago or 10 years ago, you would never want to practice without an OCT as a retina specialist. As a retina specialist, I really would not want to practice without the availability of this modality or really any of these modalities. And, so we're going to, sorry.
Did you talk about, like, I think the OCTA with CSCR, because I think that's the one time where it's even better than fluorescein angiography, because with CSCR, you can get subretinal fluid and what looks like leakage, and the angiography is often confusing, and you can get these choroidal neovascular nets that are kind of well hidden, and oftentimes occur right at the edge of where the subretinal fluid is, kind of in the outer retina there. So OCTA is actually preferable to fluorescein angiography. So I think that's the one time where it's been proven clinically, and done some research, not myself, but there's been good research on that to show that it's beneficial in that situation. So
yeah, I agree. Another great point, especially with CSR, because if it's CSR and there's no choroidal neovascular membrane, which is what we see most of the time, we're going to treat that either conservatively by watching, or a great treatment is photodynamic therapy. Versus if we see that there's a choroidal neovascular membrane, then we're going to treat it with anti-VEGF. And so, I think that's another great example of, we didn't really know quite what to do with this technology maybe 3 or 4 years ago, but another great area of where this has really sort of helped our clinical practice. So I think we're going to see, as OCTA gets better, as the image acquisition gets faster, because then that means there'll be less motion artifacts. And then as the area that we're able to image gets larger, I think we're going to see this, be used more and more over time. And I think it's just like OCT. I mean, you can see quotes of, people 20, 25 years ago saying, what's the point of OCT? This is a test looking for something for us to do. We don't know what to do with it. And, clearly now, how could we practice retina without an OCT? And so I think we're going to see the utility of this get more and more over time as the imaging gets better. Another new imaging modality, well, not new, but of the OCTA, is the Optos company about a year ago came out with an Optos camera called the Silverstone, which combines their fundus photography with a wide angle OCT. So basically, you can click on the color fundus image, and then the machine will do an OCT anywhere in that area. And the hope is, and this is where people think the technology is going, that eventually that will sort of carry over to OCTA as well. And you'll do your wide angle color fundus photo, and then you'll do a wide angle OCT angiogram, and you'll be able to see all of the blood vessels over the entire retina. And there's already some research instruments where you can do that, where you can essentially do an OCTA of the entire retina, but not yet available in commercial. Okay, so I'm gonna take the rest of the time to talk about OCT. And I'm gonna go a little more detail of OCT, because I think this is something that most people have in their practice and probably used a little more on a daily basis. Probably not a lot of folks are doing fluorescein or ICG, but really doing a lot of OCT. And I think really the key with all of this imaging is really, one of the buzzwords in retina, as we call it, multimodal imaging, is that, we want to get a picture of what's going on in the retina with as many different modalities as possible. We want to do our exam. We want a color fundus photo. We want autofluorescence. we want to do an OCT angiogram, a fluorescein, an IC green. You can do a B scan. And, obviously not every patient needs every imaging modality, but all of these different imaging modalities are giving us different information from the retina to really help us, one, understand what's going on with the patient, understand the pathophysiology of what's going on, and then once we understand the pathophysiology better, then better understanding how do we treat this and how do we help these patients. And so OCT obviously is non-invasive, non-contact, and there's no radiation, which makes it an extremely safe imaging modality. So, sometimes people like to refer to OCT as like an X-ray of the retina, but sometimes I don't really like using that analogy with patients because X-ray sort of implies radiation, and that can make patients a little nervous. Obviously, it's painless. It's very fast now. It's reliable, reproducible, and it's very sensitive with great resolution. Sort of just one slide on this, because I sort of find it helpful to understand the difference of how OCT has progressed over the years. So, we started with what's called a time domain OCT. Let me flip one forward here. So essentially, the top picture here is what's in the old sort of time domain OCT, which is sort of the beginning of OCT. And again, this is a very simplified, because again, no one really understands the math of this and Fourier transfer and who knows what all that means. But basically, essentially with the OCT and the time domain, there's a light source. The light source sends light to the retina. It's reflected back from the retina, and the time that it takes to come back is measured. And so essentially, that's a time domain OCT. And those OCTs were able to do about 400 A scans per second, just sort of for a baseline. So then the next thing that came along, which was a huge advance, and this is probably what most of us have in our offices now, is what's called spectral domain OCT. And so essentially what spectral domain OCT is basically the light that's sent towards the retina. When it comes back, it's dispersed by a spectrometer. And then essentially that allows for the receiver to essentially measure multiple different points in the retina at the same time. And so basically that simultaneous collection allows for much faster scanning versus a time domain. And the other big thing is that the reason why it's faster is that with the time domain, the detector actually had to physically move in order to measure different points, whereas with the spectral domain, that detector doesn't have to move. So by allowing the simultaneous collection and getting rid of that physical movement that has to happen, you can see we jump from 400 A scans a second to, I know this is a large range, but say most OCT machines are going to be between 30 and 50,000 A scans per second. So you can see, obviously, that's a huge jump. And that's the reason why we go from this time domain to this spectral domain with a lot better resolution. Now, the most recent upgrade in OCT, and there's a limited number of these machines commercially available, is essentially what's called a swept source. And in the swept source, the actual light source itself is changed. And so essentially the wavelength of the light source changes over time as well. And again, through the math, that allows two advantages over spectral domain. One, we get an improvement. So we can get up to 100,000 A scans a second, which is going to decrease motion artifacts, allow faster scan resolution. And really, that's going to be a huge advantage on swept source OCTAs, because the faster they can scan, the less motion artifact there is. But you also get this better scanning depth, which we can see on this photo here. So these top two pictures are spectral domain OCTs. And then this bottom picture is a swept source. Now, with our traditional spectral domain OCTs, the retina is essentially always in good focus because that's what it's designed for. But a lot of times, if you're trying to image, the vitreous or you're trying to image the choroid, you really need to select one of those two things. A spectral domain OCT is not good at imaging vitreous and choroid as well. You really need to sort of pick one of those depths. And so you can do what's called an enhanced depth OCT, where you can get a little better, but then again, you sacrifice resolution in the vitreous. Whereas the swept source, you can see that you get good resolution of the entire posterior pole. So we get really good resolution of the vitreous, really good resolution of the retina, and really good resolution of the choroid, all in one scan. So that's another advantage of swept source OCT. So OCT has a fantastic correlation between the OCT and anatomic correlation, with all of those different anatomic layers of the retina well represented in the different bands we see on the OCT. And generally, the dark bands are going to be where there's less signal reflected, which is going to be the cell layers. So in the layers of the retina where the cell bodies are, like the outer nuclear layer, the inner nuclear layer, there's less material in there, there's less reflectivity. So that's why it's going to be these dark bands on the OCT. Whereas in the plexiform layers, where all the axons are, there's a lot more material in there. And so you're going to get more reflectivity. And then that's why you get these sort of brighter bands in those layers. And then, and again, this is really an ideal scan in a perfect patient who has perfectly clear media. In a lot of patients, it's hard to see this much detail in the outer retina. But you can see, these 4 different bands where we have an external limiting membrane, the ellipsoid zone, this sort of cone outer segment zone, and then an RPE Brooks membrane zone, where you can see. And, I would say a lot of the OCTs we probably end up seeing 3 bands here. A lot of times you can see an external limiting membrane, you can see an ellipsoid zone, and then you can see your RPE Brooks layer. Okay, so there's a number of different ways that you can acquire OCT. So it's all essentially all based on lines. So these B scans are essentially these different lines that we take through the retina, these cuts, and then you can do different patterns. There's a grid pattern, which we've really gotten away from in our practice. I don't think anybody really is doing grid scans much anymore. The good thing about the grid scan is that it was very fast acquisition, but the problem is, there's areas that are missed. You can see, in these boxes here, if something was very small inside that box, you would miss it, or you're also missing these 4 corners here. So we've moved more towards raster scans, or more sort of high concentration scans through the center of the macula. So here's an example of a raster scan where the lines are all lined up from top to bottom. And then this is an example of a star or a radial pattern, where instead of the lines going top to bottom, they're going around in this circle. And the advantage of this sort of star or pattern is that it really gets very high resolution imaging of the fovea itself. And I'll show some examples of where that's really helpful. The main places that I get the star or the radial pattern is on macular holes or sort of pseudo holes. Okay, so now we're going to go through some examples of some OCT pathology. So this is an example of a macular hole. And obviously you can see here in the middle that there's tissue missing from the retina. And so that's where our macular hole is. So this would be an example of what we call a stage 1 macular hole, where there's this area of a defect in the outer retina, but it's not full thickness. But as you'll see on the next slide, this is actually an artifact of the OCT. So when you take that same patient and you do a radial scan pattern, you can see that it's actually a stage 2 hole. And so this is really a good example of really why we've gotten away from these grid patterns, is these grids can really miss things. And obviously this is an example of something that would be a huge change in treatment, because a stage 1 macular hole like this, we're going to watch this, where when the patient actually has a full thickness hole, this is now this patient needs surgery. And so that's really a good example of, keeping in mind the limitations of the OCT, different artifacts, and really being sure that what you're seeing is really what is happening there. And so the OCT is great for, so important for macular holes for just so many reasons. One, obviously diagnosis, but it also helps us in prognosis because we can see how big is the hole. That helps us determine the prognosis for closure. You can also determine, or sort of do your best to determine chronicity from looking at it, based on how the edges look. That can help us figure out if is this more of a recent hole? Is this a hole that's been there for a long time? Because it's interesting, the last 3 patients, over the last month that I've seen with macular holes, all 3 of them couldn't tell me when the macular hole was there. They had no idea whether it was there for a week, a year, just no idea. So, so based on the OCT, I can try to give them a guess of how long it's been there and sort of help with prognosis. And then it's also critical for surgical planning, because the thing about closing macular holes is all about eliminating traction and allowing that hole to close. So the OCT will let us see, well, is the vitreous attached there? Is there an epiretinal membrane? And those 2 things are really going to help us determine what do we need to do to fix this macular hole and how do we go about fixing it for the patient. So this is an example of essentially a schisis that's developed. So you can see that there are these sort of splitting of the layers of the retina. And that's an example of schisis. Now, just looking at this, this sort of definitely has a look of schisis, but, it also, in another clinical scenario, could be cystoid macular edema. So, again, this is why multimodal imaging of the retina is very important. For a patient like this, most likely I would get a fluorescein angiogram, probably get an OCTA as well, to be able to just be sure, am I treating foveal schisis, which is observation, or is there some leaking going on in the retina, which is a very different treatment. So really, again, the common theme here is multimodal imaging of the retina is really going to allow us to determine that we're really treating what we think we're treating and doing it the correct way. Oops, sorry, we sort of skipped forward here. So here, this is sort of just contrasting, a stage 1 macular hole with what this is, but this is actually a small subfoveal pigment epithelial defect. And so you can see, the big clue, like if we go back, even though we know this is not a stage 1 hole, but this is what a stage 1 hole would look like. The big difference here is you can see that the RPE Brooks membrane is still intact, whereas here you can see that the RPE Brooks membrane is actually elevated here. So that's how we know, well, this is actually a pigment epithelial detachment versus the other one was a stage 1 macular hole. And just going back to, again, sort of following these layers across. And a good tip that I do, because a lot of times if you look at the area of pathology, it's a little hard to tell what layer is what because they're distorted and it's not the normal anatomy. So a lot of times what I'll do is I'll try to go out to the side and find an area of retina that's normal. And then it's sort of a lot easier to figure out, okay, well, here we have the external limiting membrane. Then we go down and we have our ellipsoid zone. And then underneath it, we go down and there's our RPE layer and say, okay, well, now we know what those layers are. Let's follow those into the area of pathology. And then I think that's just sort of an easier way to orient yourself rather than going right to where the pathology is and the layers are all distorted. So this is an example of somebody with a lamellar hole. But again, being mindful of OCT artifacts. So depending on it, so this is the same patient, taken at 2 different time periods, but it's really more just where the scans are placed. You can see here, this clearly looks like a lamellar hole. Whereas on this scan down here, this could be confused with a cyst or some type of fluid leaking. And it's just where that scan is taken. And so, it's a balance between doing an extremely dense scan, which will take longer for patients, versus less scans, but then you can miss things due to artifacts. And we've really been figuring that out with our new machine we got, which is the Heidelberg. The Heidelberg, you can do 8 scans, you can do 16, 32, 64, 128, all within the same area. And it's a trade-off. You go up to the 64 and you get this amazingly high resolution, very dense scan where you're not going to have any of these artifacts happen, versus, but it takes a lot. The scan acquisition time is long, and therefore that means it's going to be difficult for the patient because the software is going to want to line things up, and whenever they move, it's going to pause, and so it can end up being very difficult. So it's always a sort of give and take of how dense a scan you want to get. So just another example of a lamellar hole with some vitreous traction. You can see the vitreous sort of tracking down here. So a couple of these I'm going to sort of go through a little bit more quickly because we're coming towards the end of my time and want to sort of show a couple different things. So these are just some examples of cystic changes in the retina. So an example of a patient with mild diabetic macular edema. And then an example of a patient with severe diabetic macular edema, where we can see the dark spots, which represent fluid. So essentially less, an area of the retina where there's less material, so it's going to be dark, versus these bright spots, which represent exudate. So cholesterol deposits or other material, which then appear bright on the OCT. And then somebody also with diabetic macular edema, but now they also have a component of subretinal fluid as well. And then here you can see this is somebody with a large microaneurysm right here in the center. And consequently, patients with these sort of large cysts or large microaneurysms they're actually pretty resistant to getting those to go away with anti-VEGF. So it makes it a little harder to get those to go away. And then here's an example of a patient with diabetic macular edema, but essentially mostly resolved. Now, the other thing we can see from this picture is that, well, the macular edema has gone away, but the retina is actually fairly ischemic. And so the way we can tell that is, again, we can see there's something's not right here in the center. So we go back out to a more normal part of the retina and we can see, okay, well, here's our external limiting membrane, here's our ellipsoid zone, here's our RPE Brooks membrane. And then as we come in, well, the RPE and Brooks membrane is really the only layer that's left. The external limiting membrane and the ellipsoid zone really have essentially started to disappear in the center. And so that's indicative of a very ischemic retina. And unfortunately, somebody who's probably not going to see great, despite the fact that we've actually treated this. So just another example of CME. So let me sort of skip ahead to some other examples. So this is a patient with a myopic macular schisis and some traction. And so you can see this is a very myopic looking OCT. And one of the clues on the OCT that is very myopic is that instead of having the nice straight across appearance, it has this sort of big dip. And that's despite the software trying to smooth it out, because obviously the back of everybody's eye has a curve to it, but the software does a really good job of trying to straighten that out. But on a very myopic with like a staphyloma, even though the software tries to straighten it out, it still is going to have this sort of big curve. Then you can see here after a vitrectomy and ILM peel, a much better appearance. So just sort of other cysts. So let's go into some other things. So this is an example of just a very typical ERM. And just like everything, I think the OCT is extremely helpful in prognosis of ERM and surgery, because we can look at the fundus and we can see that there's an epiretinal membrane there. But I think the thing that's the most helpful for me and really determines, when I'm going to operate and, how well the patient's going to do, I think, is really looking at the center of the retina, at the fovea, and is the ERM thickening the center? So have we lost that foveal contour, and instead you sort of have this sort of mountain? Those patients tend to do better with ERM surgery because we can remove that ERM, we get rid of the traction, and then you can a lot of times get that foveal contour improving. And so in those patients, I'm very optimistic that they're going to have a great improvement in their vision. Versus some other ERMs, you actually see it go the other direction. You start getting a very deep fovea, you get some thinning in the center. And while that's certainly not a contraindication to doing the surgery, and those patients can still do well, I'm a little more cautious in sort of counseling those patients because I find that removing the ERMs when they have that very deep foveal contour, a lot of times we don't get as good an improvement as when the ERM is the other direction. So again, why do an OCT if you can see that there's an ERM on the fundus photo, or sorry, just on your fundus exam? Well, again, I think it's really helpful in determining prognosis. And then it's also extremely helpful in surgical planning because we can go in and see where are the surgical planes. So maybe in this patient, maybe not the best example because I wouldn't grasp in the fovea anyway, but let's say this is actually a little higher up in the retina. Well, if you have these two different places, here's an area where there's some space already between the epiretinal membrane and the retina, and here maybe it's closer. Well, then I would want to come over here and maybe try to start the peel in this area. So it's also really helpful for surgical planning. And again, also very helpful in surgical planning in diabetes. So this is an example of a patient with diabetes and traction, and really trying to figure out where can we get into those surgical planes and where do we already have some separation between the traction and the retina. And that's going to be a much safer place to enter and start the cutting. So I think we're just coming to the last one or two slides here. So some examples of vitreofoveal adhesion. Here's somebody with asymptomatic versus somebody here who would be more symptomatic and then, would be more likely to need surgery. So with vitreofoveal traction, if the patient doesn't have any symptoms, then in my mind, I don't see a reason to do surgery on the patient. But I will watch that person closely and talk to them about the symptoms that could get worse. Versus when it's symptomatic, that's when it's good to do surgery. Let's see if we have any. So just an example of a patient with some typical drusen, pigment epithelial detachments and dry macular degeneration. And here we should have a good one of some. So this is an example here of what's called of an RPE tear. So essentially this area right here is where the scrolled and rolled up RPE is. And then here, this is essentially an area where the RPE is missing. And then this is also very helpful on geographic atrophy. Well, how do we know the RPE is missing here? Well, you can sort of follow the lines across, but it's actually a little challenging here to really see, what line is actually going across here. But the big clue is you can see this sort of waterfall effect that we're getting right here. And essentially what that waterfall effect is that's essentially an artifact where the signal is now able to transmit better because the RPE is missing. And so that's always a clue that there's either atrophy or an RPE rip when you get this sort of increased transmission. So to try, I'm going to sort of just skip to the end here. Because I think I am out of time, and that's I want to leave a couple minutes for questions.
Dr. Kanoff, question for you. If swept source is superior to spectral domain, why has it not been adapted more readily by everyone?
I think it's mainly a cost issue. The machines, they're newer. It's more complicated scanning, new research, and so the machines are very expensive at this point. And really, until the last probably 12 or 18 months, they were really only available under research protocols, and so they weren't FDA approved. I believe there's one or two FDA approved swept source machines. But again, it's always a benefit. It's always a cost benefit, right? What's the benefit we're getting over our spectral domain OCT versus, buying a new $100,000 machine. And that's always sort of the cost benefit. And so I think if we were starting from scratch and we had no OCT machines, then I think it would be worthwhile to get a swept source OCT machine. But I think the benefit is not for everyday clinical practice is not big enough yet to audience or.
Yeah. So Dr. Canoff, we got a question that said, when should the optometrist start doing a baseline OCT for beginning dry macular degeneration? For example, if I see 2 to 3 small macular drusen spots, their vision is 20/20, 65-year-old patient, when would you want to start OCT screening?
Yes, that's a great question. So I might be biased because I'm retina. But in my mind, if there's any abnormality in the macula, if it's not 100% normal looking macula, I would get an OCT scan just to sort of see what's going on and just better understand what's causing it not to look 100% normal, and then sort of follow that over time. I don't know if Dr. Noble or Dr. Manry have a difference, but we might be biased because we essentially get OCTs on everybody. But really, I think as soon as you see 1 or 2 drusen, it's a non-invasive test, I would get an OCT.
I see a lot of patients too who have exudates, or you can have these subtle retinal changes, and it's hard to know what layer those changes are in. And I have patients I've seen who get referred for drusen, and it's not drusen, it's an intraretinal abnormality. And so anyone over the age of 50 is going to get an OCT in my clinic, and probably everybody's going to get an OCT. So I'm biased. I think we all are in retina, but yeah, there's should be very little reason not to get an OCT.
Yeah, I think if a patient is not 20/20, or questions make this really fun and interactive. So the more questions you guys have, just keep throwing them out, and that way we can tailor what we're talking about to really what's of interest. So the questions are very much appreciated, and we really enjoy them.
So now we will switch to Dr. Preek. She'll take over control. And as a reminder, we'll have the QR code up for longer after the session. So during the Q&A, I'll have the QR code up for everyone.
Okay. So switching gears a little bit, staying in the back of the eye. Let's see here. Sorry. Hopefully get this up. So I am going to be talking about non-glaucomatous optic neuropathy. And this is a huge topic, and it is impossible really to be able to really comprehensively go through things that could fill an entire textbook. But what I'm going to try to do is talk about things that are more common. And I think for anybody over the last couple of years who has been here when I've been giving a talk, I really like to show cases. So my presentation is going to be full of a bunch of cases, a little bit less kind of information on studies, but I can answer certainly questions towards the end. And in the past, a lot of common topics we talk about when we're in the glaucoma realm are topics about artifacts in OCTs. And just like we saw with retina, OCT is so commonly done of the optic nerve, and there are so many abnormalities that can come up. And, whenever I'm looking at referrals that are sent for abnormal OCTs, my priorities are to first look to see if I'm thinking there's any artifact, or if I think that it's a really good quality scan. And then obviously always to think about things that are not glaucoma. While glaucoma is definitely the most commonly seen optic neuropathy in everybody's clinic, there are a lot of other things that can mimic glaucoma, and that's what we're going to talk about today. And we all know that glaucoma is a progressive optic neuropathy that's characterized by cupping. And, typical things are that you have slow vision loss that's usually bilateral, field loss following the horizontal midline because of the way the retinal nerve fiber layer runs, central vision typically spared until pretty late in the disease because the papillomacular bundle is not affected early in the disease. And generally the color vision is spared. So we all know these things. But it can be hard to distinguish between glaucoma and other optic neuropathies because glaucoma can present with cupping and normal pressure, and so can a lot of different optic neuropathies. So this is what we're going to look at today. So first case, this is a patient of mine referred a couple of years ago, 68-year-old gentleman, had really poor vision care, meaning he had never really had problems with his vision. So he didn't have regular eye exams, hadn't had eye exam for many, many years, came in complaining of a film over his vision in his right eye for a few months. His acuity was 20/30 in the right eye, 20/20 in the left. And he had an APD in the right eye. He had normal color vision, pressure a little bit high on that right side with a thin cornea, no family history, and quite a bit of cupping in the right eye, but not in the left eye. So a patient like this comes to see me. These are his visual fields. His right eye, which is the eye he's complaining about, has this clear inferior arcuate defect, superior arcuate. Left eye looks pretty normal. And when I see a person like this with really asymmetric disease, first things I'm thinking about are, well, he's cupped, so that looks like glaucoma. His pressure's a little bit high, that looks like glaucoma. Thin cornea, but very asymmetric. So things that I'm thinking about, has he had some sort of injury in the eye that would make his one eye prone to having this cupping? Has he had any previous surgery in the eye where he could have some sort of secondary glaucoma or potentially some sort of old ischemic optic neuropathy? Previous steroid use that may have caused some really high spike in pressure in the past that sort of improved over time. Signs of any secondary glaucoma, so pigmentary or pseudoexfoliation glaucoma, which commonly will be very asymmetric. So first things I'm going to think about are to think about those things and then ask also about neurologic symptoms. So from a standpoint of neurologic symptoms, flags that would come up in somebody's history would be rapid vision loss, because that's not common with glaucoma unless their pressures are 50 or 60. Color vision loss, again, not common in glaucoma. Associated symptoms that would be unusual also for glaucoma would be pain, double vision, feeling that the eye is bulging, headaches, loss of smell, any sort of paresthesia, spatial numbness. So actually in this gentleman, he doesn't really have any of these things. He has sort of a slow change in his vision with this filminess in his vision. His color vision was normal. He didn't have any of these other things. And despite that, he had quite asymmetric disease. And so I did end up neuroimaging him, although, the cupping and the way he presented actually, I thought were glaucoma. And I did some imaging to be safe. And his imaging actually came back normal. And in this particular case, even though he's super asymmetric, I think that he does have glaucoma. He's been on drops for the last several years, pressures in the low teens in both eyes. And his OCT and field, which I'm not showing here, have been very, very stable since I started seeing him. So this is just to say that, asymmetric cupping is always something that looks like a flag, but asymmetric cupping absolutely can be glaucoma. There have been a lot of studies that have been done about talking about, is it worth imaging people who have cupped discs, and specifically people who have cupped discs with normal pressures. And this is just one kind of very seminal paper that came out quite a long time ago, where they looked at a bunch of people who had presumed normal tension glaucoma, and they imaged them, and they didn't find anything abnormal on any of these patients. So when you see patients and they do have typical cupping in both eyes, they're older, the way you would expect in glaucoma, visual field defects that look very classic for glaucoma, most of the time the yield of imaging is actually quite low. But the types of things where you want to really think about imaging are when the patients are younger. Young patients don't often get low tension glaucoma, so that's definitely a flag, a young patient with a normal pressure. Patients with reduced vision, because that's just not that common in glaucoma unless they don't present until they're end stage. And then obviously certain visual field defects that would be atypical. So I'm going to just show a couple of examples of things that don't have cupping, but that are very commonly, I feel like I see these types of cases all the time in the clinic, referred for concern about glaucoma. So this is an 82-year-old who was transferring care, diagnosed with glaucoma 4 to 5 years ago. And per the patient, As far as she could remember, pressure was somewhere around 20 before she had cataract surgery a couple of years ago. Her corneal thickness is quite thick, over 600 in both eyes. So just right there, thinking about that, like, oh, okay, well, that 20 is really not that high for a person with such a thick cornea. She had cataract surgery and eye stent placement in both eyes. And then, even after the eye stent, she's currently on 2 drops in both eyes. So she's on timolol latanoprost with a pressure of 15. And this is her field. So, here, right eye looks probably pretty normal, maybe a little artifact here. Left eye has the sort of inferior arcuate type defect, which certainly could go along with glaucoma in that left eye. And then this is her OCT, which her right eye looks pretty normal, consistent with her normal field. Left eye, has the superior temporal thinning with GCC loss, again, could go with glaucoma. I'm going to get back to that, not the perfect way to look at cupping on an OCT, but you look at the OCT and you're like, oh, well, it doesn't look that cupped, but has this nerve fiber layer loss. And then these are her cups. So, she really has minimal cupping. Right eye looks pretty normal. Left eye, again, pretty small cup. She does have like a little bit of a not totally clear right here disc margin. It looks like she has a little pallor kind of right in this area superinasally. And, this patient on the autofluorescence, what you can see is she has drusen. So she has optic dysdrusen in that left eye. They're very visible on the autofluorescence. And in her case, my feeling is that she does not have glaucoma and that she has this field defect due to drusen. And really probably doesn't need this treatment that she's been on for such a long time. Drusen certainly are pretty common. I see them all the time. They're often bilateral and they can migrate towards the surface over time. They can cause RNFL loss in patterns that look exactly like glaucoma, and they can cause visual field defects. They themselves cause the visual field defects, and there is no proof that putting somebody on drops changes that or changes the course of that. I will say in my practice, generally, if a person has drusen and they have elevated pressure in the setting of drusen, while I might see some people with ocular hypertension and not treat them, I probably would lean towards treating these patients since they already have stress on their RNFL. But in a person with a normal pressure and a field defect with drusen, typically I'm just going to follow them over time. So this is a patient that I saw years ago and was sent to me for an opinion about this visual field defect. And disc photos are at the bottom. I know this left one looks like there's some pallor of the disc, but I really think it's more of an imaging artifact. Clinically, it didn't look that pale. But you see sort of this field loss, and it's kind of all over the place in both eyes. It looks like maybe there's a superior arcuate. There's something down here. Right eye, mostly nasal field loss. But if you look at the discs, the cup in the left eye definitely doesn't look cupped. Definitely doesn't look like glaucoma that would cause such extensive field loss. And the right eye also cupped kind of on the smaller side. And this was the patient's OCT. And so, you have field loss and you have a lot of OCT change. And I think the default generally is that you think about glaucoma, and that, is totally a reasonable thing. In this right eye, there is this very superior inferior pattern of RNFL loss. In the left eye, it's a little bit more diffuse, so a little bit less like what you'd normally see. The interesting thing on this patient is the macular analysis, ganglion cell analysis, and you can see, really has sort of loss on both eyes that really follows kind of a vertical pattern. And that is something that is definitely very suspicious. So when you see that, whenever I see something like that, I always think neurologic causes of field loss. And you could have already, before I even showed you the OCT, thought that because the flavor of the visual field is a little bit more of a left-sided defect there. So when patients have some sort of pathology in the optic tracts, optic radiations, back to the visual cortex, for sure, you can get this transsynaptic retrograde thinning of the RNFL, and we can see that on OCTs. So when you're talking about field loss and RNFL and things coming from potentially something that's not glaucoma, it can be hard because patterns, I think, of RNFL can be very variable. If you're just kind of looking at this picture, what I'm trying to show here is that if a person has nasal field loss, so they had hemianopic loss and the eye that we're looking at has nasal field loss, you know, the nasal fibers come from, or the fibers that are responsible for the nasal field, they come mostly from the superior inferior retina. And so having that can definitely give a pattern that looks like glaucoma, having that superior inferior field loss. When people have more temporal field loss, the fibers actually come from everywhere. So there's contribution from everywhere, and that's where you can get that diffuse field loss type of pattern. When you look at GCC, it's a little bit easier sometimes to tell patterns that look a little more neurologic because they have this more hemianopic appearance on a ganglion cell analysis. And so this particular patient was sent for neuroimaging, and he had this right-sided encephalomalacia that was consistent with his, or sorry, right-sided encephalomalacia consistent with a left field defect. And then this was just a person I saw recently. This is slightly different. You know, that patient that I had previously seen didn't give a history of any sort of previous problem that he was aware of, but this was an 82-year-old recently sent for worsening glaucoma, had already been followed as a glaucoma suspect for many, many years due to large cup to disc, and then was started on drops in 2020 because of a concern over a change in her OCT. She had no family history of glaucoma, relative, average thickness cornea, and her pressure, she's been followed for quite a long time, so there's a good history of her pressure, has always been low. So most of the time under 14, lots of times between 10 and 12. And she has a history of a known right occipital stroke that occurred in October of 2020. And so these are just pictures of her discs, and she does have large cups, and like I said, she's been followed for quite a long time, so that's always been present in her eyes. And these are her fields, her current field. She used to have normal fields, and now she has this clear neurologic defect. I don't think anybody would look at this and think that this was glaucoma. And this is from her occipital stroke. But what becomes difficult in patients like this is patients like I mentioned previously that have strokes do over time have RNFL changes, and they have GCC changes. And so now you've been following this person as a glaucoma suspect for years. They've had a stroke, the visual field fine, looks like glaucoma, but now you have these changes in the RNFL, and you have to figure out, well, what do I think about these changes? And is this something that, you need to be concerned about? Certainly people can have two diseases, but you look at the whole picture, right? In her case, again, it's not a perfect hemianopic defect, but she certainly has this ganglion cell loss that's more kind of on one side here. And the interesting thing about strokes is that there have been plenty of studies that have showed that people really have progressive RNFL change after a stroke, and it can go on for years. So, it's not just an immediate thing that happens right at the point of the stroke. The fastest loss in the RNFL is in the first couple of years, but there are some studies that show that it goes beyond that. So this patient is about 1.5 years out of her stroke. She's had a completely normal pressure, and I have no reason to think that she has glaucoma, and that this change can definitely just be from her stroke.
Real quick, Dr. Parikh.
Sure.
Dr. Bartlett had a question. Have you had a patient with DON, an elevated intraocular pressure, and have you recommended surgical intervention given concerns for central vision loss?
Did you say TON?
DON. I'm not too familiar with that acronym.
So we're talking about traumatic optic neuropathy. Is that? I can't see the question. So.
Oh, okay.
Is that what we're talking about? Traumatic optic neuropathy?
I don't know what the D stands for in DON. Drusen of the optic nerve.
DON. I thought it was TON. Sorry about that.
Drusen. Yes.
So if a person has high pressure with optic neuropathy or with drusen, I personally have not operated on anyone like that. I will say that I do know of some colleagues who have had patients who had progressive vision loss. It's quite rare that people with drusen get central vision loss. They usually don't, although I've seen some fields look terrible with kind of central islands. But it's very uncommon that they lose central vision. However, people who get those really rapidly progressive fields, I do know of a few cases where people have operated on them. I will say those couple of cases I know of, it didn't really make a difference, but I think it would be a very rare situation where we would be thinking about operating on somebody like that. So hopefully that answered the question. So I'm going to switch a little bit. You know, the couple of things that I showed, those are conditions that are generally not associated with cupping. I still all the time see people diagnosed with glaucoma, even though they're not cupped. But, you know, I think everyone looking at that when people show examples would say, yeah, it's not cupped. So that's not something that flags a person necessarily for glaucoma. But I'm going to switch just to talk about some things that actually cause cupping. And then that becomes very difficult sometimes to tell the difference between what's going on. I guess let me take that back. If you were just looking at pictures, and the point of looking at some of these things is that history is so important in these patients. And so we're going to talk about the things that help you determine differences between glaucoma and these other conditions that can cause cupping. So this is not a patient out of the clinic, but I just wanted to show this just because I couldn't find good pictures of a patient in our clinic with this. But this is a 45-year-old patient who came in with vision loss. And, you know, just looking at this with, and I have all this imaging, I know because I pulled it off the internet, so it kind of gives away answers. But, you know, looking at this, you have a young patient. So that should be a little bit of a flag right there. You have a patient who's complaining of vision loss. So that also typically not seen in glaucoma. This patient, you can see in this right eye, which they're complaining of their vision loss, there clearly is more cupping on the right eye compared to the left eye. So that's very obvious on this picture. My feeling would be a patient who had a disc like this that was actually glaucoma, would they be complaining of vision loss in their eye? Probably not, because you know, there is rim left everywhere. So this is not someone who's completely cupped out, which are the more typical patients with glaucoma that complain of vision loss. And then you can see sort of an OCT at the bottom, and this patient has on the OCT, the RNFL much more changed temporally, and then has ganglion cell loss. And so, you know, in this particular patient, the patient had neuroimaging and was found to have this mass with a compressive optic neuropathy. So compressive optic neuropathy is one of the things that can cause cupping and vision loss. Again, the vision loss should be a flag when you see a patient who has cupping in one eye with the vision loss. It should be a flag to think about something that's not glaucoma, even though you have these OCT changes where you might think maybe this is glaucoma. Compressive optic neuropathies can be caused by several different conditions. Pituitary adenomas are probably the most common thing that we're going to see in the clinic. Pituitary adenomas will generally, if their patients are complaining of vision loss, will cause kind of a more of a slower progressive vision loss, but an apoplexy can cause sudden vision loss. So sometimes patients may come in complaining of sudden vision loss. Aneurysms, there are blood vessels that run very close to the optic nerve, and so there are aneurysms, the internal carotid artery, especially that can cause a compressive optic neuropathy, craniopharyngiomas, and then meningiomas. And the presentation of these patients is going to depend on where the compression is occurring. So if they have compression in the intraorbital segment of the optic nerve, then you're going to see swelling on your exam. But if they have compression in the intracanalicular, intracranial portion of the optic nerve, then you can see atrophy, pallor, and cupping in these types of patients. I just want to show an example because this is just something that happened to be seen this week. This came out of Dr. Noble's clinic. It goes more in the first category, but he saw a young patient, 23-year-old, referred for disc edema in the right eye, complaining of progressive blurred vision in the right eye, and a strain when looking to the side associated with some loss of vision, positional loss of vision, had a decreased acuity on that right side, 20/50, 20/20 on the left eye with an RAPD, had gone in just to have glasses checked, thinking that needed a new prescription. And the doctor who saw her noted that she had disc edema in the right eye and referred her urgently for an evaluation. And so these are a picture of her disc, but just looking at this, you can just see the right disc has very blurred margin and the left looks okay. And she was sent for neuroimaging, and her particular images, there weren't good images I could pull out, but she came back with an optic nerve sheath meningioma. And this is just an example of what imaging would show of an optic nerve sheath meningioma, where you get sort of this enhancement along the optic nerve, and you can see on the cut here, this kind of enhancement around the optic nerve. And so optic nerve sheath meningiomas are conditions that they can occur in the intraorbital portion, but they can occur further back as well. And so you can get cupping in this particular condition. They're usually unilateral, affecting women more often than men, usually younger women, and they usually have slow growth and slow progressive vision loss. And associated with these transient visual obscurations and gaze-evoked amaurosis, so gaze-evoked loss of vision, sometimes a headache, sometimes proptosis. And these are generally treated with radiation. Of course, this one is a little different because this patient came in with disc edema. Disc edema almost always is going to prompt imaging. But just to know, you can get cupping with a patient like this as well. So things to just always keep in the back of your mind. So this is another patient out of the clinic, 47-year-old woman, referred for worsening visual fields. And she had originally been seen by her previous doctor about 5 months prior to presentation at our clinic. And she had at that point been complaining of vision loss in both eyes for several months. She had no APD, visual acuity was 20/25 in the right, 20/40 in the left. And she had corneal thickness in the 5/20s. And I'm going to show you her field in a second, but she had field loss at presentation and she was started on drops for glaucoma. And these are her nerves. Again, she has, you can see she has slightly enlarged cup to disc on both sides. And this is one of the reasons the previous doctor was concerned about glaucoma. And this is her field. So, her original field up here. And, I think at least per the records, there was a question. They did think that, this maybe just wasn't a good performance field, and felt that based on the exam, they were concerned about glaucoma and had the patient come back to repeat the field. And then when the patient came back to repeat the field, again, complaining of vision getting worse, and you can see much more diffuse depression across. Obviously, in this first field, has kind of this very temporal on the left and right field loss much more. So this was the OCT, and the other interesting thing again about the OCT is, has this GCC change that really follows the vertical on both sides, kind of nasally in both sides, corresponding to that sort of bitemporal change on the field. And this patient was sent for neuroimaging and found to have a really large pituitary macroadenoma with compression at the chiasm, and had a resection, and did feel that her vision improved some after. In these types of patients, generally the improvement occurs in the first couple of months most of the time. And it is possible for some patients who are caught early to have a resection and for the visual field to resolve completely. That's more common if there is a normal OCT at baseline. And so this is her follow-up field. You know, her OCT looks extremely abnormal, so it's not surprising that her field defect didn't resolve. And she isn't the best test taker. You can see here she has a lot of false negatives, and that can give this sort of cloverleaf kind of type pattern on the side, but she subjectively felt that her vision was better, and this was better than her previous field. So chiasmal lesions can really present in lots of ways. You can get lots of different types of field defects. The classic is the bitemporal defect, but they might be incomplete. And so, you know, these are things to just really have a high suspicion for when you're looking at fields. Sometimes you can have visual field loss in just one eye, depending on where the compression is. And in a junctional scotoma, which is what this is, you can have sort of a diffuse field loss in one eye and then more of a temporal field loss in the other eye.
Now might be a good time to just intervene. We've got a couple great questions that have been coming up. So Dr. Parikh, Dr. Wolford just asked who you usually send these patients to with things like that for potential surgery and intervention.
Okay. So I will have to say that I have referred these patients to groups and not a specific doctor. It's not so many people that have come up. So I've sent most of these patients that I've seen, which, like I said, have only been a handful, to Boulder Neurosurgical and Spine, but not someone specific. I don't know, actually, maybe Dr. Kanoff has someone specific he has used.
I know, at least for my patients that I've seen,
Where are you?
I don't have any kind of specific place that I've sent people to. UC Health for neurosurgeries, you know, pretty good. There's Blue Sky Neurology in the area as well. And then there's some other neurosurgical practices in kind of the Boulder County area too. Some of it depends a little bit, in my experience, on patient preference of where they want to go. Typically, as soon as you say the words brain surgery, they'll often want to go to Denver. But there are some more local options as well too.
Yeah.
And then another question, which we could maybe save for the end too, but for circling back around to strokes, and when you're talking about strokes, one is there anything that you can do to slow down that nerve fiber layer loss? Is there any treatment that that seems to make a difference? And then kind of the second question is, how do you kind of educate these patients with changes after stroke loss, especially you know, over time? And when should they be referred for ophthalmologists to evaluate them, and when should the, you know, optometrists continue to follow?
Yeah, they're great questions. You know, as far as I know, there's no treatment. I mean, this is due to the damage that was done at the time of the stroke, you know, in the brain, and what you're getting are these transsynaptic changes going forward. So as far as I know, there's no treatment to be able to change that. Generally, these are a lot of times ischemic strokes that have caused a certain amount of damage in the brain, and then you're just seeing the consequences of that going forward. These patients, you know, typically they're going to have these homonymous field defects, and from their perspective, sometimes depending on what area in the brain was involved originally, how much swelling there was, sometimes some of those defects do improve. But, you know, often when you see this very classic like a homonymous defect on one side, no macular sparing, they're not going to improve, but they don't generally worsen. These patients who have these RNFL changes over time, you know, typically I'm not seeing that their vision is necessarily getting worse. They usually will maintain a pretty, but they'll just maintain this field defect. It doesn't generally change over time. You know, if a person is sent to me for a glaucoma evaluation because of these RNFL changes, you know, I'll often show them the imaging and tell them that this can happen from their old stroke. I do continue to follow them, but I have not run into situations as of yet of patients whose vision seems to be affected by this down the line. And from a standpoint of following it versus referring it, I think at any point, if there is any sort of feeling of discomfort about the change occurring on the OCT, and, if there's other factors going on, like a high pressure, cupping, or anything that kind of complicates things and is a little concerning, I think that it's always useful to get another opinion from somebody and refer, just, to feel more comfortable yourself and cover yourself, because certainly in these age groups, a person could potentially have a stroke and glaucoma. So it's not necessarily, they're not always exclusive of each other. Were there other questions that popped up? I'm seeing little.
We're getting a number that have just come in.
Let's see.
We could do some of these now, or if you want to kind of keep going with your presentation.
Yeah, why don't I, these
so.
These two that I just see right now, why don't I just talk about them at the end? I'll try to just go through some of the other things a little bit more quickly, so there's time to talk about all of that. This is just an example. This is actually a 23-year-old that was transferring known pituitary adenoma that he had resected, so it was not a diagnostic dilemma, but just to show another example of the fact that, he actually did have symptomatic field loss. He had the resection. He, at this point, feels very asymptomatic. He doesn't notice anything, but this is his residual field defect after resection. And, his right eye definitely more affected than the left. And you can see there's a difference in how both eyes are affected. That's not uncommon. And on the OCT, it correlates. So in his right eye, you can see he has more change on his OCT compared to his left eye. Especially in his left eye, he has a little bit more, a less GCC change here, which goes along with the fact that the left eye has a little bit less residual field defect. But always interesting. I think it's always interesting to look at these things and see how well they correlate. So you have this temporal kind of change, and you have this GCC change right there, right along the vertical. So, pituitary masses, if they don't have compression, they don't have significant field loss, sometimes these patients are not going to have surgery, and then you're just going to be monitoring them. This happens to be just the way I follow these patients. I typically will do visual fields on anybody who has adenoma that is large enough to have a concern for compression, maybe not causing anything now, maybe deferring surgery. I'll do fields twice a year. If somebody has a resection, get a post-surgery field. And like we already mentioned, vision can get better after resection, but if there's significant change on OCT, their field defects are likely to persist in some way. And I think it's very useful to have a baseline OCT at the time of diagnosis if this patient presents to you as an eye care provider. And then to get OCT after. So I'm just going to switch to a couple of other common things. So this is, again, coming out of our clinic, a 61-year-old complaining of vision loss in the right eye, saying that has sudden loss of inferior vision in the right eye, and had taken him actually to the emergency room. So he had already had imaging at the emergency room. They had done a CAT scan, a CTA, and they had done some blood work, and he had a normal ESR CRP, asymptomatic in the left eye, a history of ventricular tachycardia on these medications. So blood pressure, the lisinopril, heart rate control, amiodarone for heart rate control, presenting with an APD in the right eye, visual acuity of 20/30. And these are his discs at presentation. And left disc looks normal. And I hope, sometimes photos can be hard, but I hope you guys can appreciate that, in the right disc, he has this blurring of the disc margin, mostly superiorly, and basically had disc edema of the superior disc margin, and had this field defect, inferior field defect, just like he was complaining of, symptomatic in that right eye. What's tough in this guy is, when you see patients like this, this is a typical presentation of a NAION, but he's also on this medication. He's on amiodarone. Amiodarone is a drug that can cause a toxic optic neuropathy. And so now you have these two things. I'm just throwing out in this case, like I said, maybe not quite as straightforward. Amiodarone typically causes a slightly different presentation. It tends to be more bilateral and sort of a slow change in vision, usually not this very acute symptomatic change of this patient who's complaining of an inferior field loss, and he could tell you that I woke up with this. But regardless of that, having this as in his history, there was a discussion with his doctor and the amiodarone was stopped. I think the presentation looks a little bit more like NAION. But this is a picture of the optic nerve 1 month after he had this episode. So you can see a lot of the edema has resolved. You can see the disc margin much better. There does appear to be some pallor compared to the other eye. And then this is a year afterwards. And, the thing to see here is that he is now slightly more cupped than he is in the other eye. Does have some pallor of the disc here, and hopefully if a patient like this ever presented to you, they're going to tell you that they had a history of this problem happen in their eye. And so you're going to know that something had happened in the past. But if they, a person like this doesn't volunteer anything, certainly you'd want to ask, because, I would look at this, and if a person came like this and I didn't know any history and I saw that field, I would think, well, that's a little bit odd, because while there's a cup to disc asymmetry, if this was glaucoma, I would expect there to be more superior loss, notching, vertical cupping that was displayed superiorly to explain that inferior visual field defect. And in here, while this is more cupped than the other eye, you don't have that focal cupping, which is more typical of glaucoma. And again, there is this pallor. So, in these types of patients, you would say, have you ever had an episode like this? You try to elicit some history if they were a good historian. This is his OCT 1 year post this event. And you can see, even though he had really superior disc edema and the GCC is a little bit more superior loss, he kind of has this diffuse change in the nerve after this episode. Again, probably more likely NAION, although no way to totally exclude that the amiodarone could have been involved there. So ischemic optic neuropathy, NAION, is going to be the most common thing that we see in our clinics. Generally older patients, usually you're going to see disc edema if they present to you acutely, often complaining of sudden vision loss that is either a top half, bottom half, more common bottom half, often upon awakening. And they're generally going to have vasculopathic risk factors and some of the other things here, sleep apnea, shock, so some sort of hypotension during some sort of surgery, and then phosphodiesterase inhibitors also can be associated here. NAION, you usually get this progressive atrophy, generally stabilizes about in the first year after an event, and there's no proven treatment here, although we often will recommend aspirin without really great evidence. And then this is just another patient that I had seen recently. She was transferring care. She'd been followed in Texas for years, diagnosed with glaucoma in 2017, had been put on drops and had an SLT. She had cataract surgery in her left eye a couple of years later. But again, she said that she was only treated in her one eye. They had never told her there was any concern for glaucoma in her left eye. She had a thick cornea, no family history. I got records and didn't have any really clear high pressure at any point in her history. She had some decreased vision in that right eye and an APD. And I don't have a great disc photo of her eye. She has cataracts in that eye too. So it wasn't a great photo to show this, but on exam, she had some pallor of the disc in the right eye. And this was her field. And I had asked for old fields, and I had gotten this old field from 2017, which is on the right, from when she was originally diagnosed. And she's had this very stable kind of inferior field loss. And, to me, again, I'm sorry, I don't have a photo of the nerve. She just really wasn't cupped enough to explain that. She had some pallor of the disc in that area. And, my feeling with her is that my guess is she probably had a vascular event at some point. I'm not really convinced that she has glaucoma. But this is her OCT since I've been following her in her right eye, again, with a sort of diffuse thinning that's been very stable. And her left eye, she has a lot of vitreous traction, so there's a bunch of artifact here, but she has a very normal looking disc on the left eye without cupping. And so, to me, having this asymmetry and this pallor in the right eye makes me think most likely this is probably not glaucoma. AION is the one that everybody always worries about, missing temporal arteritis. Temporal arteritis generally is going to present in patients who are older, and it affects medium and large arteries. And so it can have a predilection for the ophthalmic artery, posterior ciliary arteries. And because of that, people can present with pretty sudden, severe vision loss. And I just put this up actually just to show that cupping is very, very common in a person with temporal arteritis that has the optic nerve involved. Some of the studies have shown that over 90% of patients who had temporal arteritis will have cupping in that eye and quite a bit of pallor. And these, again, this is not something I think that would generally be confused with glaucoma, because this is going to be a person with extremely poor vision in that affected eye. And they're going to have had a sudden loss of vision if you were to get history from them. But sometimes some of these things come up and they can become hard when you're seeing patients who are transferring care and you don't have good records, and they're elderly and maybe have some dementia and are not great historians, and their family members maybe don't know lots of history. And so it's always something to keep in the back of your mind that this can cause cupping as well. I'm going to try to just skip through it. I'm not going to say much about this. Optic neuritis can also cause cupping. This is just an example of a person who had optic neuritis in their left eye. And you can see they have this clear cupping in the eye with pallor. And I'm going to just briefly talk about this case. This was someone who was referred maybe last year for a visual field defect in the right eye, coming for a glaucoma evaluation. And this was her field defect. And, I look at this field and I think, okay, well, this is an interesting looking field. It's a little bit more paracentral. It doesn't extend all the way nasally. It's not so classic for glaucoma, but clearly has a field defect. This was an asymptomatic patient, had no complaints about their vision, gone in just for a routine exam, had no APD, had pretty good vision in both eyes, had pretty normal pressure with thick corneas, had a history of some heart surgery, and that's all they could recall, and they were on some blood thinners. And these are the discs, and certainly, the patient does have some cupping, and on the right eye, which is where that field defect is, maybe superiorly a little bit of cupping, so for sure on the disc. And this is the OCT. I'm just gonna have you guys ignore the bottom on the left. This is just an artifact here, imaging artifact, but on the right eye has this sort of superior RNFL change with this GCC change. And I just put this up because the correlation is so beautiful with the field defect, where you see how this loss is right here, kind of sparing this area and then sparing this nasal little area there. But this patient, you can see on their OCT, has quite this drastic intraretinal change here. So intraretinal atrophy corresponding to this area that we're seeing the change on the GCC and where the field loss is. And this type of drop off is not seen in glaucoma. This is something that you see with an artery occlusion. So in this particular patient, I think that they had a branch artery occlusion, and they are asymptomatic from it. And CRAOs and BRAOs can cause some pallor and cupping. And so you can see that, usually kind of more of a shallow cupping and not so much excavation the way you see in glaucoma. But branch retinal artery occlusion is always, in my mind, differential for normal tension glaucoma if I'm seeing someone with a unilateral change in their eye. And you can scan the retina and get these very classic OCT changes. I'm going to skip, I think. Actually, I'm going to just show this because it's interesting. I'll skip the last couple of cases. This is one of Dr. Canoff's patients. Really interesting patient, elderly female who came for a maybe second or third opinion, I don't know, to see him complaining of dimming vision in both eyes over the year prior to presentation. She had been seeing somebody and she had some cataracts, and they thought that taking the cataracts were going to help her vision, and she had cataract surgery and she felt that it didn't help, that her vision was better prior to the surgery and that her vision was continuing to get worse. She was also aggressively being treated for dry eye. So she had this reduced acuity. She did have dry eye changes on the exam, but felt to be not extensive enough to explain this visual acuity, had no RAPD. And on her history, she was on B12 supplementation because she had had quite an extensive intestinal resection 5 decades earlier. And these were her discs. So, you know, I think they maybe slightly more cupping, nothing I think that stands out significantly on the discs. And these were her fields, which just showed this very kind of generalized reduction of sensitivity. So you can see, you know, she just really has reduced sensitivity, mean deviation here on the right eye down at -8, no maybe clear pattern on this. But, you know, Dr. Canoff, astute, concerned about maybe some sort of optic neuropathy, and decided to send her for some imaging and do a nutritional workup, given that she had this intestinal resection. And her vitamin B levels came back normal, but she came back with an undetectable vitamin A. And this patient has had vitamin A supplementation. On her most recent exam, her vision's improved to 20/25, and her dry eye has gotten improved. Dry eye is one of the things that can be seen with vitamin A deficiency. And really interesting, vitamin A deficiency, you can get these this loss on OCT that actually improves with treatment. So this is one of the few things that I've found that you can actually see some improvement in the measurements on the OCT. So really interesting. You can see that her ganglion cells, it actually has thickened over time. And this is a known phenomenon in vitamin A deficiency and treatment. Just one thing to keep in mind when I looked at this, you know, I thought, oh, well, you know, one of the things that would be kind of a flag as to an optic neuropathy on this right eye was that, you know, had just much more central change on the OCT, and the RNFL not so terrible. And the left eye, though, didn't have that same pattern, so that could confuse you. But, you know, I look at this and I think this is just, from looking at a lot of nerve OCTs, this nerve fiber layer just looks very strange, doesn't look normal. And that is because this patient happens to have an ERM in this left eye that has causes quite a bit of distortion, pulling the nerve fiber bundles a little bit more temporally. And so you get this sort of weird look here, and you don't get that thinning here because they have this change from the OCT. So actually this left eye, the reason, my guess would be if she didn't have this ERM distorting thing, she would have an appearance a little bit more like the right on the OCT. So nutritional optic neuropathies, just things to keep in mind when patients have had a gastric bypass surgery or have sometimes inflammatory bowel syndrome, liver disease. These are situations in which we can see nutritional deficiencies that can cause optic neuropathy. And this is just an example of a bateau spot in the which can be caused by vitamin A deficiency. You can get these sort of keratinized dry patches, normally temporally, but temporally or nasal on the conch. So I think I'll skip these couple of other things because they're just much less common. But, you know, I guess takeaway I would say is there are things outside of glaucoma that cause cupping. So, you know, always want to keep that in the back of your mind, and anything that's atypical on a history might prompt you to either, you know, send the patient for a referral or potentially, you know, think about doing further workup. But the flags would be patients who are younger, patients who are complaining of vision loss, visual fields that have secocentral vision loss, or visual field defects that tend to more respect the vertical midline. You often in these patients will see some stuff crossing the midline. They're not always perfect, but when they mostly respect the vertical midline, that should be a flag. Color vision loss and pallor. And I think color vision loss is something that, you know, I'm guilty of not checking probably as much as I should. And maybe you guys are better at that, but I think that it's really, pupils and color vision can be really helpful in people where you see some atypical things worthwhile checking. If you are seeing a patient that even if you think they might have glaucoma, but some things are weird about them, that's a great place to start in the clinic. So I will just stop there and happy to go back to questions that were asked. I don't know if there are other questions that came up. So what I'm seeing here, Matt, let me know if there's anything else. I'm seeing, and try to get your pressure down. It's probably not going to harm you. But I think that just like you're getting at, it can be really difficult because these things, we love to use OCT to help us, but sometimes OCTs make our lives harder having some of this data. So if there's anything else, I'm happy to answer. I don't see anything in the question box right now.
Well, I think for the sake of time, we'll keep moving and continue in kind of the retina world, but start talking a little bit more about cataracts and Dr. Noble. And then once again, we'll have the QR code up for you afterwards during the discussion for you guys to scan it for your credit.
Well, thanks, Matt. I'm Carl Noble, one of the new retina people here. And if I haven't met you in person, hopefully we can meet in the future. I wrote a book chapter for Steiner, which is one of the cataract books that is kind of the Bible for cataract surgeons. And we wrote a chapter on retina considerations for cataract surgeons. And I thought this would be a good talk that I kind of condensed into a PowerPoint presentation for referral doctors who have patients who have cataracts and kind of deciding if they need to have any other considerations from the posterior perspective prior to getting their cataract surgery done. We're going to talk about preoperative assessment, peripheral retinal pathology, diabetic changes, vasculopathies, macular degeneration, and then I have some good examples and kind of some stuff for you guys to take screenshots for medication toxicities and then some OCT findings. And we'll also talk about briefly inherited retinal diseases. So really important for patients with cataracts before considering surgery to make sure that they have a good preoperative assessment and really identifying and managing posterior segment disease to discuss with patients on their vision potential and also to avoid some major pitfalls that can result in patients being very unhappy after their cataract surgery. As a retina doctor, I'm extremely biased, but I think OCT of the macula is an important part of a preoperative assessment, and especially to evaluate for macular degeneration and vasculopathies like vein occlusions, artery occlusions, or diabetes. It's especially important when evaluating patients for premium lenses like multifocal lenses, even torics, to best assist them with preoperative expectations, which is kind of the name of the game for cataract surgery. And also want to make sure that we have a good peripheral retinal exam, as we don't want to be taking a cataract out on a patient with a retinal detachment or high risk for retinal detachment. Peripheral retinal pathology, as a retina doctor, Dr. Mannery, Canoff, and myself can see a lot of patients referred for peripheral retinal changes. And the question is, should we treat this? Should we not treat this? And I think the very broad answer is, it depends. And so asymptomatic retinal breaks, meaning that the patient is there for a routine exam, they have no complaints of new floaters, flashes of lights, any curtain vision changes, that would be considered asymptomatic. And outside of the setting of flap tears, or also called horseshoe tears, there is really poor and low clinical data to support treatment of those peripheral changes. With an asymptomatic horseshoe tear, though, these tears result in retinal attachments in greater than 5% of cases. And so it is still a recommendation in what most retina providers would recommend treating asymptomatic flap tears. Now, symptomatic tears, especially flap tears, and let me make sure this is clear, flap tears that are symptomatic, meaning a patient presents with flashes and floaters, they have a new PVD, and they have a horseshoe tear, those result in retinal detachments in 50% of cases. Now, a retinopexy will reduce that risk to less than 5%. And so that's obviously very important that those patients get treated as soon as possible to minimize that risk of progression to retinal attachment. But again, the data, when you look at an asymptomatic horseshoe tear, because that implies chronicity, that the treatment is still important, but there is less of an urgent and less of a risk reduction when treating those patients, because it's probably been there for a while. Now, when we talk about lattice degeneration with or without atrophic holes, operculated retinal holes, and atrophic round holes, these rarely require treatment. There are some caveats to that, and all of us retina doctors use different metrics for when we would or would not treat these patients, and a lot of it goes back to where we trained and how we were trained in our previous clinical experiences. But I will say that there's no strong clinical data in the research to support treating these types of peripheral pathology. Now, in my personal opinion, if a patient has had a retinal attachment in the contralateral eye, they're going to get laser if there's anything in the peripheral retina on the unimpacted eye from a retinal attachment. If there's a strong family history of retinal attachments, or if they have high risk occupation or risk factors, if they're like a bull rider or a professional kickboxer, maybe they're a professional headbutter, those would be things that have a lot of bludgeoning force to the skull. They're probably at a higher risk for detachment, and doing preventative laser would be beneficial. I always ask about professional headbutters, but that has, no one has actually has that occupation, but I'm going to continue to ask patients. The risks of laser retinopexy is really quite low. And so if there is any kind of, if I'm on the border of treatment, I usually err on the side of treating. This is some examples. Top left is a flap tear or horseshoe tear. And I'm assuming you can see my cursor. You can see that the base that tear is still connected to the base of the retina. This is higher risk because fluid can kind of get underneath this flap, and this area just remains more patent, or there's less of a adhesion between the retina and the RPE here, and fluid can get underneath the retina and cause it to attach more easily. So this would require treatment, in my opinion, with every single case, especially obviously in the symptomatic patient. This is an example of lattice degeneration with atrophic holes. And this would be on a case-by-case basis. And this is an operculated retinal tear. It looks like there's a subretinal fluid cuff, maybe some early pigmentation. And this would not be unreasonable to treat versus observation depending on the patient's clinical scenario. Talk about diabetic retinopathy and in the preoperative setting for cataract surgery. And just really wanted to reiterate that diabetes is a vascular disease. High blood sugar can cause chronic damage to capillaries, which results in damage to the tight junctions of the capillaries, pericyte loss, and macrophage infiltration, as well as overexpression of vascular endothelial growth factor. All of these result in leaky vessels that ultimately can result in ischemia. And this is where most of the pathologic changes from diabetes results from. So proliferative disease is when the eye is not getting enough oxygenation. The retinal vessels are trying to compensate for this and create new vessels, or neovascularization, that are crappy vessels. Those things break, they bleed, they can cause tractional components and detachments. And this is one of the major causes of severe vision loss for diabetic patients. Preoperative OCTs for anyone with diabetes is very important. And the proliferative diabetic patient, looking for subtle membranes of the looking at hyaloidal membranes, which is the vessels, they actually grow from the retina into the vitreous. And this posterior cortical hyaloid can become thickened and very taut. And that's what results in prehyaloidal contraction as well as tractional detachments. So it's important to determine how visually significant these membranes are. I would also caution anyone from using silicone-based lenses and multifocal lenses in patients with diabetic proliferative maculopathy, as these can result in silicone lenses, very poor visualization if silicone oil is needed for retinal attachment repair, and also multifocal lenses can result in very unhappy patients from contrast sensitivity issues. Oftentimes, these patients are going to need cataract surgery and vitrectomy. There's good data to support that doing a combination surgery is safe and effective for patients, but oftentimes staged approaches are utilized effectively as well. It's important that for these patients to set realistic visual expectations preoperatively, as oftentimes foveal ischemia can result in poor visual acuity, regardless of how nice the retina can look after a good surgical repair. Just for patients who are being seen in your clinics, every diabetic, I ask the same questions. When were you diagnosed? So how long have they been a diabetic? What is their A1C control? Are they on, if I could spell, inusulin is not a new type of insulin, that is just a misplacement of letters. But are they on insulin, and do they use multiple daily injections, a pump, or a CGM? And I ask those questions just to see how facile the patient is with their insulin therapy. And it also tells me how well they're controlled and how well they're plugged into their management. So if patients using a pump and CGM, I often find that they have better control or at least more buy-in into their therapy. And then I ask about renal disease or chronic kidney disease, and then peripheral neuropathies, and then the last time they saw their primary care doctor or endocrinologist. Those questions usually take about a minute or two to gather that information, but I think it's important for me to kind of assess where the patient is and where they're going with their diabetic care.
I'm going to interject, Dr. Noble, and just comment on that. You talked about combination cases versus staged for cataract. A lot of times for some of these cases, especially if we know it's a pretty complex tractional detachment, and there's a high likelihood that we're going to put silicone oil in. A nice kind of elegant way to take care of both of those is if we're going to be inducing a cataract with our surgery and the oil, taking out the cataract at the time that we take the oil out tends to be a good approach.
Yeah, I think that's what a lot of us do. And it's these patients oftentimes need more than one surgery. And so doing a staged approach for cataract removal is really nice. And it avoids them having a third or a fourth surgery in some of these cases. So thanks for bringing that up. This is an example of a patient who had something called crunch. And I'm not sure if that's a familiar term for outside of the retina community, but there's a risk with patients who have proliferative disease. And in this patient, you can see the upper photo here. There's an area of localized tractional detachment. And this feathery, lacy looking vessels here is neovascularization. And he has a significant amount of prehyaloidal or contraction already and thickening of the posterior cortical hyaloid. And it looks like an epiretinal membrane. You can see this white band here, but this is actually really the hyaloid or the vitreous. And you can see here, this is actually neovascularization of the vitreous here going towards the disc. And so that's NVD with thickening of the vitreous. And that's what causes a lot of pathologic changes in proliferative diabetic retinopathy. There's a risk with anti-VEGF and laser that the patient's hyaloid can actually contract as the VEGF load drastically and suddenly decreases. It can cause contraction of those bands. And in this patient, you can see a marked change on the OCT, maybe a little bit more subtle if you're not looking at what's going on in the photo, but there's contraction here along this superior arcade, worsening retinal detachment. And then on the OCT, you can see that this area is markedly contracted. We're seeing schisis here and a little bit of subretinal fluid over here, but marked loss of vision for this patient who went from 20/40 to 2400 after pan-retinal photocoagulation for this patient. They did very well. We ended up doing a vitrectomy, removing the posterior cortical hyaloid in the membranes, and the patient recovered their vision in this case. For diabetic macular edema, OCT is very crucial to, again, to diagnose and manage patients who have diabetes, to look for diabetic macular edema. I often tell patients that with diabetes, it's a project that we're going to need to manage them for usually 6 months to a year with proliferative disease just to get them stable. And then from there on, not as frequently, but it's going to be a lifetime project to keep their eyes under control. This graph here is taken from the DRCR NET protocol T, which looked at diabetic macular edema and followed patients over 5 years. And they're looking at Avastin, Lucentis, and Eylea. You can see here that the biggest improvement in visual acuity occurred in about the first 3 to 4 months. After that, it kind of plateaus and stabilizes. And you can see that there really wasn't a huge difference between the different anti-VEGF agents and the visual recovery and results between the 3 agents in this study. And so it's safe and effective to use any of the anti-VEGF agents included in the study for patients. And obviously, I think Dr. Maynard's going to talk about some of the other medications that are, not included in the study that are maybe a little bit newer, but the bulk of this to take away is that anti-VEGF works, but for patients who have significant macular edema, I recommend 3 to 4 treatments prior to cataract surgery to stabilize the macular edema. I also often find that patients with macular ischemia don't respond as well to either anti-VEGF or steroids. And so this can be more difficult to manage in patients with severe macular ischemia. And then it's important that cataract surgery doesn't disrupt injections. So I often recommend that a patient receives an injection 2 weeks before and then 2 weeks after cataract extraction, as cataract surgery in and of itself can cause worsening diabetic macular edema from increased capillary incompetence from inflammation in addition to the diabetic disease. Also, as previously mentioned, when there is concern for prehyaloidal contraction or an epiretinal membrane, this may be contributing to the diabetic macular edema, and either a stage or combination approach with a membrane peel may be important for these patients. And then more for the cataract surgeons themselves, but adding 40 milligrams of preservative-free dexamethasone into your infusion bottle can often help reduce inflammation.
I'll interject again to just say I agree a lot with what Dr. Noble says on this. Yeah, when it comes to diabetic macular edema and treatment, kind of in the perioperative cataract state, I approach it a little bit differently from how I do in kind of the routine management. If we think about diabetic retinopathy and diabetic macular edema as an inflammatory disease, which a lot of these are, then cataract surgery, as we know, stirs up more inflammation. So that can lead to destabilization of the diabetic retinopathy. And so, I'll usually agree, with anti-VEGF therapy. And sometimes if have patients where they're in their gray area and they're at the range, and I'm typically, maybe they have a little bit of diabetic macular edema, they're 20/20 or they're 20/25, and I haven't treated it, I might actually, do an injection or 2 before cataract surgery just to make sure that it's not going to flare up and be that much worse afterwards.
I completely agree. And I have a decent amount of patients that I have been treating just 2 or 3 injections before surgery and then 1 after surgery. And then I plan on just monitoring them. And oftentimes they don't need long-term therapy because they're 20/25 or better with trace amounts of macular edema. But there's been several cases I've seen where not not pre-treating these patients, their diabetic macular edema just blows up after cataract surgery, and it becomes much harder to control after that occurs.
Yeah, so sometimes these patients, and I agree with that, they might get started with a short course of injections, but they're not the people that then go on to need lifelong treatment.
Yeah, exactly. This is just an example of a patient who has diabetic macular edema. The upper OCT, you can see there is an attached vitreous here. That's this gray line. There's areas of cystoid spaces with areas of exudate. There's also thickening of the outer retina here, and then subretinal fluid. Their vision was 20/40 pre-injections, and this fluid very nicely resolved after several anti-VEGF injections with improvement in their visual acuity and subretinal fluid. I'll also mention for people, and I think this comes up a decent amount, and there's good papers that have analyzed this as well. I think it'd be difficult to determine CME versus DME. I know this is not really part of my talk, but I think a lot of people struggle with OCT interpretation. But looking for hyper-reflective material in the macular edema is very important, and one of the biggest clues that should lead you towards a diagnosis of DME as opposed to CME. And there's some exceptions to that, and it's not a hard and fast rule, but it does greatly contribute to the diagnosis of diabetic macular edema versus just cystoid macular edema. This is an example of a vasculopathy where a patient was seen preoperatively and noted to have significant vision loss. You can see in the colored photo that there is scattered dot plot hemorrhages, cotton wool spots. If we were to zoom in here, the nerve is swollen with flame hemorrhages surrounding, and this is consistent with a central retinal vein occlusion. The OCT here, you can see an attached hyaloid, marked cystoid edema here. No appreciable subretinal fluid here, but this would be considered severe cystoid macular edema. And after therapy with anti-VEGF injections, that edema has resolved. There was improvement in visual acuity, but you can also see there's some subtle changes in the temporal macula and some early ischemic changes that we can see with vein occlusions. Moving on to, and one caveat with the other vasculopathies like vein occlusions, I treat those the same way as I would a diabetic macular edema, where I would want them controlled to optimize their macular edema for several months prior to cataract surgery. I also did not include inflammatory or uveitic patients in this talk, but CME is another important thing with inflammatory CME to control for several months with either PO, intraocular, periocular, or topical steroids for several months prior to cataract surgery, because that is also another inflammatory condition with pro-inflammatory factors from the surgery itself can make it very difficult if it's not pre-treated to treat postoperatively. So moving on to macular degeneration, this is something we'll all see pretty frequently, and it is an age-related risk. So patients who are 65 have a much lower risk than patients who are 75. Smokers, always important to ask patients if they're smokers, and just another reason why they shouldn't smoke, as this is really the only modifiable risk factor and very highly associated with an increased risk of progression. Family history, lighter pigmented patients or lighter colored eyes, and there is an increased risk among women. Wet AMD affects 10 to 20% of macular degeneration patients and is responsible, though, for 90% of severe vision loss, whereas dry macular degeneration affects 80 to 90% of patients, but responsible for about 10% of severe vision loss from geographic atrophy. So this is very common in the cataract surgery population. Up to 50% of patients in some cohorts have AMD and cataracts when initially presenting. The range of visual impact is astronomical, all the way from completely nothing to count fingers, severe vision loss. And it's important to look for things like drusen, RPE irregularities, or pigment epithelial attachments, as well as geographic atrophy when looking at patients with dry AMD. OCT is crucial, as Dr. Canoff and we were discussing earlier. OCT is super important when evaluating patients with macular degeneration. It should be a pretty low threshold for anyone to get an OCT, let alone if you're seeing pigmentary macular pathology on your fundus exam. But you can see the irregular contour from drusen and optical transmission defects from outer retinal or photoreceptor loss in areas of RP dropout in geographic atrophy, as Dr. Canoff previously showed. And the treatment for macular degeneration is dry. And as far as approved by the FDA therapy right now, it's smoking cessation, AREDS vitamins, and then periodic screening exams with frequent home monitoring. This can be done with an AMSA grid or home Werner acuity monitoring devices. This is an example of a patient who was complaining of poor visual acuity in low light settings and very unhappy after a multifocal intraocular lens placement. Visual acuity was 20/40, best corrected after cataract surgery, and is considering an IOL replacement with a monofocal lens. And this is a patient who had a multifocal lens placed, and this was either not discussed or not appropriately reviewed with the patient, that there is significant drusen here and confluent drusen centrally on the fundus photo. And on the OCT, here you can see that the inner retina appears intact. The outer retina, you can see some pigment migration here. And then when you look at the RPE, you can see this irregular RPE consistent with drusen that becomes more confluent in the peri and foveal regions. And so this patient with their complaints of contrast sensitivity are heightened when using a multifocal lens, as patients without macular degeneration can have issues with contrast sensitivity. Macular degeneration with these patients, they need more and more light to have the best vision possible. And the degrading contrast they get with multifocal lenses is often a very difficult thing for patients to adapt to, and are often very unhappy. Obviously, this patient's also paying out of pocket for this lens at a premium, and so that is not contributing to a happy and satisfied patient in the postoperative period. Moving on to wet macular degeneration. Again, OCT, as we've discussed earlier, is super important for distinguishing wet versus dry. Patients who do have wet macular degeneration, that vision recovery is often associated with early detection and treatment. We see improvements in both vision and OCT anatomy that correlate, and this typically takes anywhere from 3 to 6 months of therapy with anti-VEGF injections. Most patients, I tell, in the clinic, I tell most patients that almost everyone we can reach stabilization, but about 50 to 60% of patients actually improve their vision with anti-VEGF injections. And while there's no indication that cataract surgery itself promotes conversion from dry to wet macular degeneration, I often like to stabilize the wet macular degeneration prior to cataract surgery for several months, but there's no contraindications of doing cataract surgery in a patient with wet macular degeneration.
This is maybe, oh, sorry. Yeah. This is maybe a good time to ask a question that came up regarding, kind of in the newer patients, the dropless surgery and dropless cataract surgery.
Yeah.
Patients with pre-existing, retinal vein occlusion, wet AMD. Specifically, what was asked about was DME. And what are your thoughts on that?
Does dropless surgery impact?
What's your impression or recommendation about dropless surgery in patients who have macular pathology?
I don't see a contraindication to using dropless surgery. If the patients with vasculopathies like vein occlusions, diabetic macular edema, I think dropless surgery is fine. I think it's more important they would be pre and post treated with an anti-VEGF agent. For patients with uveitis, I often would recommend a subtenon's Kenalog injection, 40 milligrams after surgery or in the perioperative period once they're stabilized. I think that would be appropriate, but it's not inappropriate to use dropless surgery. But I think you have to take it on a case-by-case basis for the uveitis patients. But for diabetic and vasculopathies, then I think VEGF is the bigger driver of control than whether you're going to use drops or not. Does that answer the question you think, Matt?
Yeah, I think so. I have, yeah, I agree with that. I think pretty well. Yeah, I think that you can certainly do dropless for those patients. Dropless might not hold their, Irvine gas CME as well. So I usually will have a conversation with the patient that we might, have to, resort to using drops or consider a subtenon's Kenalog in those patients, or an anti-VEGF. But it certainly can be tried. Depends on how severe it is kind of going into it probably too.
Yeah. And I like I was saying, I think uveitis patients, I would be more likely to use a very strong steroid, either orally or periocular, or even intraocularly in the perioperative setting for uveitis patients. But again, case by case, I think the vasculopathies, can be an inflammatory drive, but they usually respond very well to anti-VEGF. But using a preoperative Ozurdex injection, for instance, for a very poorly controlled diabetic is not unreasonable at all. Oh, so I didn't go through this example here, but this is a patient with wet macular degeneration, and it's an 82-year-old patient with dry who presented with new visual distortions and vision dropped from 2025 to 2200. In this color photo, you can see that there's areas of subretinal hemorrhage. There's a kind of a gray elevation right here, and there's areas of subretinal fluid as well. OCT very, very clearly notes here, you can see this pigment epithelial detachment with kind of blurring of the outer retina, areas of subretinal fluid. There's also exudates or pigment as well, and intraretinal fluid. And this patient was started on anti-VEGF and was stabilized with some minor improvement in their visual acuity. So there's a lot of other causes of choroidal neovascular membranes that it's important to evaluate patients for in the preoperative setting. And this can be from myopic degeneration, histoplasmosis, angioid streaks, choroidal ruptures. There's the pachychoroid spectrum, pachy meaning thick, choroid being referring to the choriocapillaris. And there's a lot of other disease pathologic states that can be associated with a thick choroid. And there's something called pachychoroidal neovascular membranes. Central serous choroid retinopathy falls in this spectrum, as well as polypoidal can all fall into this spectrum as well. There's inflammatory causes of choroidal neovascularization, like multifocal choroiditis, punctate interretinal choroidopathy, and there's also idiopathic choroidal neovascular membranes. So this was a patient I saw recently who presented with kind of vague vision changes in their right eye, as well as the left eye, and some issues with contrast. There on the color photo, you can see this well circumscribed area where there's kind of speckled pigmentary changes of kind of light and dark in the foveal region. On the, this is a near infrared photo. It kind of really clearly demarcates these areas of kind of light and dark speckled pattern in the fovea. This is an autofluorescence, and this shows areas where there's been damage to the RPE and also areas where the RPE is inflamed. And so kind of a mixed pattern of dying and dead RPE here with this hypo and hyper autofluorescent pattern. Fluorescent angiography showed early hyperfluorescence in the parafoveal region within late leakage, kind of circumferential around the fovea. And then OCT showed atypical RPE elevations in both eyes, and this kind of more dome-shaped elevations. And there's outer retinal thickening here and then subretinal fluid. Correlating this with the fluorescein angiography, very consistent with an active choroidal neovascular membrane. When further discussing with this patient, she noted that she was on pentosan polysulfate, and given the classic changes in the this kind of classic pattern on autofluorescence and near infrared in both eyes, this is consistent with a PPS or Elmeron toxicity. It's less common to get a choroidal neovascular membrane with PPS or Elmeron toxicity, but it has been reported in the literature, and this is a patient who was started on anti-VEGF therapy and is responding very well to date. I'm going to talk about retinitis pigmentosa mostly, but also inherited retinal diseases of the eyes. This is a very broad disease category, and even with retinitis pigmentosa, there's a lot of different genetic types that can cause these rod cone dystrophies, and over 100 different genes can be impactful. And using genetic testing on patients with irregular posterior pole findings and vision loss is becoming more mainstream because it's free. And so we have access to genetic testing kits in our office, and I have a very low threshold for ordering genetic testing for patients, as it can often help with understanding of where they're going with their disease, and also better educate their family members on the need for screening, testing, and for some younger couples to help them with family planning as well. With RP, it's very common to get posterior cortical or posterior subcapsular cataracts. This is a photo example showing retroillumination, and there's this posterior subcapsular cataract here. It's also more common to get posterior capsular pacifications after cataract surgery as well. Patients with RP often have photoreceptor and pigment epithelial dysfunction and can present with nyctalopia and progressive visual field loss. A question that comes up a lot, and I think you'll see a lot of variance in the management of cystoid macular edema in patients with retinitis pigmentosa, but this occurs in about 10 to 15% of patients with RP, and there is sometimes anatomical improvement in macular thickness that can be achieved with topical or systemic carbonic anhydrase inhibitors, and also peri or intraocular corticosteroids. But vision may or may not correlate with CME reduction and may or may not improve with CME reduction. RP patients often have significant improvement in visual function, though, after cataract surgery, despite minimal changes in Snellen visual acuity. But there's no conclusive evidence that cataract extraction worsens these macular edema seen in RP, as this is not considered an inflammatory drive causing the macular edema in the setting of retinitis pigmentosa. On fluorescein angiography, it's super helpful with retinitis pigmentosa, as there's often minimal leakage on angiography, which is contrasting to Irvin gas or post-operative cystoid macular edema, where you'll see robust disc and macular leakage. But given the overall low incidence of this disease process, there's no clinical guidelines that exist right now for perioperative CME management in the setting of retinitis pigmentosa. And there's really weak clinical evidence to support the treatment of macular edema in the setting of retinitis pigmentosa, but oftentimes it is treated by many providers. This is a patient I saw recently who has retinitis pigmentosa, or more specifically Usher syndrome, so associated with hearing loss. He's a 29-year-old male, and he has some artifact here from projection artifact from his PSC cataract, and so the optos color, this looks like is almost obstructing the view here, but that's because it's from his lens. The photo here, if it's one of the broad photo here, so the nerve on clinical exam has some pallor, and there's some attenuation of the vessels, and then there's these bony spicules or RPE pigmentary changes in the periphery. Autofluorescence is super helpful in these patients because you can see the extent of hypoautofluorescence, where there's just been diffuse damage to the RPE for this patient. There's sparing in the posterior pole, but unfortunately for this patient, he has very, very limited visual acuity from his visual field decline, and currently is only about 10% of a central visual field that's preserved. And you can imagine how all these areas where there's dropout on the autofluorescence just correlates with him having no peripheral vision. This patient also has some other classic changes with retinitis pigmentosa, which is an epiretinal membrane and this schisis-like change in the macula. He has been treated in the past with Diamox, but does not tolerate it well. And we're currently just watching this and to see if this is correlates with any vision changes with fluctuations in his CME. Briefly going to mention some IOL considerations for patients, and this is an example of something that can happen intraoperatively. But silicone lenses, an example would be a crystal lens, can have very difficult changes that are visually significant on the lens during surgery or after surgery from the retina perspective. So silicone lenses, when there's a need for silicone oil, so that could either be for a diabetic detachment or a patient who has chronic detachments or a patient who lives in a different state and needs to fly home. Often silicone oil is used in those scenarios, and you can get these very significant oil marring that occurs on the back of the lens. And it is darn near impossible to see through these and very difficult to treat patients. And oftentimes the surgery has to be aborted, use a different tamponading agent, or remove the lens for these types of cases. With oil in the eye and silicone oil lenses too, you can get permanent opacifications to the lens that can result in the need for lens extraction. You can also get with gas and fluid air exchange, significant fogging of the lens that can make it very difficult to proceed with surgery. From a retina perspective, and I think all retinal doctors would agree that we really dislike silicone-based lenses, and they can cause a lot of problems for us with both the peripheral retinal exam, but also if retinal intervention with surgery is needed. I am always very concerned about having to do a vitrectomy on a patient with a silicone lens, because any complication can be made much worse if oil would be required for that patient. There's also lenses that are hydrophilic, meaning they like water, acrylic lenses. And an example of this would be the Acryos lens. This is a lens that is designed to be put inside of the capsular bag, but a lot of doctors use this also to use Gore-Tex sutured lenses to the sclera in cases where there's not anatomical support for an intraocular lens. But these can be associated with localized calcifications during or after vitrectomy, and often in the setting of air or gas tamponade. There was a pretty decent paper looking at this a year and a half ago, and the incidence is pretty low, but it is something that's reported in the literature. I think just a general caveat that if a patient has any posterior segment pathology that may warrant surgical intervention at any time in their life, then I would not recommend a silicone oil lens. Hydrophilic acrylic lenses, like I talked about, I think it's a little bit of a softer recommendation to use or not use them. I think the incidence of those opacifications are pretty low, but definitely reported. So I have a few more slides I'll show you, but it's more just for your reference. But today just wanted to go through the importance of preoperative management and just really reiterate the importance of the OCT for patients, as we do not want pre-existing disease to get blamed for your post-operative results. And I think OCT can really help you explain to patients, you have a cataract, you need surgery, but hey, why don't we have this evaluated before you have surgery to discuss if preoperative intervention is needed. And then if no intervention is needed, it really helps the patient understand that they may not have the best contrast sensitivity or postoperative visual results because of the pre-existing conditions. Multifocal lenses, really important to avoid in patients with macular degeneration and in macular pathology, as contrast sensitivity can become drastically diminished in those clinical scenarios.
and then avoid silicone lenses in patients who have pre-existing or potentially retinal pathology in the future. So I created these as well. I thought it may be helpful if you want to just take a screenshot of these next two slides. Just some basics on OCT and kind of what you see when you're looking at OCT for different disease states. I'm not going to go through all these, but I thought this may be helpful. So I'll leave this up for another 10, 15 seconds. And kind of goes from the vitreous is at the bottom and then all the way up to the top, and just some considerations for patients in these scenarios with OCT changes. And then I know medication toxicities can be confusing. And so I created this as well and thought it may be a good reference for people if they wanted to take a screenshot. And these are some of the more common medication toxicities can affect the retina. This is a separate talk in and of itself. We talked about PPS or Almiron, but there's also Plaquenil and some other medications as well if people want to take a screenshot of this for their reference when screening patients. And that is all I have. Were there any other questions that came up?
Great. Good talk, Dr. Noble. One question that came up just towards the very end was, do you worry about the fellow eye going from dry to wet AMD if it was noted that technical updates on everything here, so. All right. Now I think this is working. Okay. So last talk, we're going to go through a lot of the drugs, and it's been discussed with Dr. Kanoff and Dr. Noble. We've been a little retina heavy on our presentations today, which is good from my standpoint. But so I'm going to kind of go over, a lot of our medical conditions that we are treating, what the current treatments are. You've seen a lot of them discussed today, but I'll go through a little bit more of the mechanism. We have a few treatments that more recently got FDA approval. So I want to kind of go over what our newer treatments are that exist. And then clinical trials and future avenues for treatments in the future as well. So we're going to talk about the mechanisms and duration, and then go from there. So as has been discussed through some of our other talks, the main focus of these today, and there are some other indications for injectables as well, are going to be diabetic retinopathy, wet age-related macular degeneration, and then retinal vein occlusions, BRVO and CRVO, typically with macular edema. But retinal ischemia and neovascular proliferative diseases can be used for treatment as well. So diabetic retinopathy, most common cause for visual impairment in working age adults. Typically, we're focusing on DME or proliferative changes with perhaps a vitreous hemorrhage that is symptomatic. You also have non-proliferative diabetic retinopathy at different levels. And there are some of our anti-VEGF agents that do have FDA approval for treatment, even without macular edema, because some of these anti-VEGF treatments can reduce your level of disease. There's a scale called the Diabetic Retinopathy Severity Score, looking at different markers. And we can see a reduction in the level of diabetic retinopathy severity with treatments. Even if vision does not change, we can modify the disease and reduce the risk of proliferative progression. From a AMD standpoint, mild, moderate, and then severe or advanced are non-exudative and dry. We're usually treating with avoiding tobacco products, taking our AREDS2 supplements, which it is actually in the AREDS2 study. A point to bring up to patients is that an AREDS2 vitamin was studied in conjunction with a standard multivitamin. So it is usually asking patients to be taking both a regular multivitamin plus the AREDS2 supplement on top of it. Sometimes you'll have the patients who say, okay, well, the AREDS2 vitamins, I don't tolerate it very well. Main side effect being probably an upset stomach, most likely from the zinc or the copper. And so I'll talk to patients about seeing, okay, are they taking those 2 tablets because it's standardly 2 tablets? Are they taking them together? One way to modify that is to have them split it up. So a dose in the morning and a dose in the evening. And then the other modification is probably the most important compounds are the lutein and the zeaxanthin. And so sometimes you can go to, Sprouts or one of those other places, and you can get those antioxidants standalone. So that's another way to have patients that are having a hard time tolerating the standard AREDS to kind of work around. And then typically eating a good healthy diet is recommended. I talk to patients about a Mediterranean diet, lots of fish, or typically, fish 2 or 3 times a week to get some of those healthy antioxidants. Exudative and wet AMD is going to be treated with our injectables typically. And Dr. Noble also discussed that not all CNVM is just wet age-related macular degeneration. There are other disease processes that can cause a choroidal neovascular membrane as well. When we're getting into more advanced macular degeneration, geographic atrophy is a large one, and then the wet and exudative form are the large one as well. There were large databases that look at populations and people who have the eye disease, and seeing a number of people who have the more advanced forms of those eye disease. Wet AMD is about 10% of our AMD patients, but can account for 80 to 90% of severe vision loss. This is one of our newer devices. I'm sure you've had the reps come into your office as well, but it's a 4C Home. It's a home monitor for Amsler Grid. It does get covered with a lot of insurances. Particular Medicare is pretty helpful, and there might be a small copay for the patients to have these devices at home. It's a way for them to kind of click on an Amsler Grid at home and check and see, compared to their baseline, if there's any newer changes there. That gets triggered to the provider that is listed that's taking care of the patient. And it triggers that, hey, there's a change that has been noted from the baseline on the device. You might want to have the patient come in the next few days for an evaluation to look for any exudative changes. The next iteration of this, which might exist with this device or another device, hopefully in the next few years, is an at-home OCT. So having integrated into the same device, a kind of more basic OCT that will look for fluid. And in the new age of AI, there's a lot of algorithms that can automatically identify fluid and kind of flag that for review by the provider of the image to see if, hey, is this fluid or not? And do you want to bring the patient in or not? Retinal vein occlusion, central versus a branch retinal vein occlusion.
Can I stop quick just to ask a
Sure.
question? So a question was, and I was going to type it, but I accidentally hit the button that said we would answer it live. So we're answering it live. Do you have thoughts on MacuHealth or MacuHealth Plus that reduce the zinc level as patients may be getting too much zinc when also taking it with a multivitamin? I can just answer this in the from the perspective of Emily Chu, who I've heard talk on this and wrote the AREDS studies that the NIH and NEI did. And anything that's not the AREDS2 formulation or the AREDS formulation is not clinically proven to statistically, in a significant way, lower the risk of progression to advanced macular degeneration. So anything that's not the AREDS formulation is has to be taken with a massive grain of salt.
when you're looking at its risk reduction. So if they're already taking zinc and these formulations have less zinc, I guess it may be reasonable if they're getting the zinc that was in the AREDS2 formulation. But just as a blanket statement, anything besides the AREDS or AREDS2 formula has not been studied. And not, if it is studied, it's nowhere near to the same scrutiny that the AREDS2 study was put under. That is one of the best eye studies or ophthalmological research that has ever been done. And so I would be very cautious when recommending alternatives to the AREDS formulations.
Yeah, and that's one of the things with if you look at the original one versus the AREDS2, when they looked at the AREDS2, was a reduction in the amount of zinc and lowering the zinc that was in that, and also, of course, the omission of the beta carotene with the increased cancer risk associated with the beta carotene in smokers. So that's why, you know, they've kind of looked and said, well, what's the best? And the AREDS2 is the best. The other formulations, the data starts getting a little weaker and a little messier. So I usually am pretty strongly pushing towards the true AREDS2 formulation. But if patients are saying, listen, I can't do it, there's a couple other workaround options there too.
And do you have patients, do you talk to them about limiting vitamin K who are on blood thinners, who are taking lutein and zeaxanthine? I do not. That was another question.
I do not typically discuss that with them.
I haven't seen an increased risk or any data to support blood thinner modification based on any of those vitamins. So I think that's outside of our scope as ophthalmologic practitioners to be changing people's blood thinners, especially in this setting.
Yeah. So going back to RVOs, the more ischemia you have, the more risk for, you know, neovascular disease, proliferative disease that's going to require treatment to prevent vitreous hemorrhage. Ischemic eyes, typically worse visual prognosis. And then macular edema, that's a big one where it's actually treatable. I mean, if you have an ischemic CRVO, you know, they've got count fingers vision, I might treat their edema and get their edema to either reduce or dry up, but their vision gets absolutely no better because there's been too much damage related to the vascular ischemia. So the macular edema is one of our nice reversible things, but just because we treat the edema doesn't necessarily mean that it makes the vision any better, unfortunately. So, you know, as we're looking at our mainstay of treatments, everyone's pretty familiar with a lot of our injectables that we have. We're using those to treat, as I said, AMD, diabetic retinopathy, CRVO. ROP is also on this slide. You know, so ROP classically was treated more so with laser or cryoretinopexy, sometimes requiring surgery, and have found over time that you know, anti-VEGFs and bevacizumab and Avastin work to reduce the progression of that disease. Interestingly, some, you know, newer studies that show even some lower doses of the Avastin than the standard dose that continue to do work to reduce that progression. So some of these slides are PTSD from medical school for me, but looking at all of our signaling pathways and a lot of this for vasopermeability, so increased vessel leakage and new vessel growth. That's that proliferation, all leading to angiogenesis. And so you have different vascular endothelial growth factor markers that are working on the VEGF-R, which is the VEGF receptor that gets activated intracellular to turn on tyrosine kinase signaling and upregulate those in the eye. So you have the VEGF, anti-VEGFs that are working to bind the VEGF that's being signaled in order to kind of reduce how much is in the eye and act kind of as a inhibitor there. So another slide that shows kind of the same thing, where you're seeing the VEGF 165 attaching to one of our receptors, leading to signal transduction in the cell, that leads to proliferation and migration and angiogenesis. So we'll start with our bevacizumab, which we call Avastin. This one specifically is used off-label, so it is not on label for FDA-approved treatment of eye disease. But as we were seeing how much this worked on the disease state of the eyes, there were earlier medicines that were used as well, which aren't really used much anymore, but began used pretty extensively in about 2005. It's also used in brain and colorectal cancers as chemotherapy. You're essentially choking off the blood supply to those tumors by taking these blood vessels and getting these blood vessels to regress. So you can see it's anti-angiogenic as you're binding the VEGF-A. And so, Carl, your mic may be on, or someone's mic may be on. But so a lot of these anti-VEGFs are targeting VEGF-A and B, which are with the very specific VEGF receptors. And so Avastin is a great generic. So we use these generics a lot of times to start patients on treatment. Cost for a lot of these maybe $100 to $150 versus our other anti-VEGF drugs can be $1,200, $1,500, $2,000 per dose per eye. And so it's a good generic. We do sometimes hit some limitations with insurance companies who want to do something called step therapy, meaning that they're mandating that we start a patient on Avastin and basically prove to them that the Avastin isn't working before they will agree to cover a more expensive drug. This differs state by state. Colorado has been thankfully spared a lot with this. We see a little bit of it, but there's some other states, particularly in the Northeast, where they get hammered with it. And basically the providers have no option but to start a patient on Avastin. Sometimes you can just give one before you said, hey, it failed. Sometimes they'll want to see 3 or 4 Avastins used before that is considered to be a failure. An interesting development that I kind of thought about this morning and didn't put a slide on, but this is something that we're going to see more so in the future, is this concept of what we call biosimilars. So basically, a lot of these drugs are manufactured in a cell. They have a network for cells to produce these drugs. They're called a biologic, and that's how these are developed. So you have some biosimilars that are coming out for some of these, they recently got some FDA approval, and we're still trying to figure out where the market will be on if some insurance companies might make us or ask us to use one of these biosimilar drugs instead of the more expensive one. Interestingly, because Avastin and bevacizumab are off-label, there's a company that's looking at having, I think, kind of a biosimilar to the bevacizumab, which would get FDA approval and be on label perhaps next year in 2023. And we're going to have to see how that changes the landscape of injections. So moving on to Lucentis, this is the one that first got FDA approval. That was in 2006. It's a smaller molecule than the Avastin, so I do have a slide on here later that shows the different sizes of these, and it has a higher binding affinity than the Avastin, and so it's a little bit more targeted in the eye, and it may also have a little bit less systemic effects. The systemic effects of the medications are all pretty low, but thought processes are that some of these that are more kind of eye specific might stay a little bit more in the eye and reduce the risk of any systemic effects. Eylea is a little bit different than the other anti-VEGFs. This one's considered more of what we would call a VEGF trap. So there's kind of this dual binding arm that has a higher binding affinity and probably binds more like 2 of the VEGF instead of just 1. So it is one of the stronger ones that seems to last a little bit longer. first got FDA approval in 2001. And actually when they first got FDA approval, it was at a Q8 week. So every 8-week dosing interval. At least initially we couldn't do it shorter than 8 weeks because that's what it was approved for. And then they went back and found, hey, yes, it works at 8 weeks, but there are patients who it works better if you do less than 8 weeks. So we do have it now approved to go down less than 4 weeks for treatment. There are some patients where we'll occasionally see that there's an additional added benefit by going less than 4 weeks for some of these. You might occasionally have a patient that comes back, 2 or 3 weeks after their injection for something, and you get an OCT and you see that it's totally dry, but at 4 weeks there's fluid. And on rare circumstances, we might have a patient that goes to what we'll call kind of a subthreshold or 4-week treatment. But that's kind of hard to convince a patient to come in every 2 weeks to get an eye injection. So those are usually pretty far and few between. Moving away from the VEGFs and looking at steroids, for most specifically DME, retinal vein occlusion, uveitis, or macular edema like CME. Steroids work really well. So the anti-VEGF, so the steroids might have a little effect for wet AMD, but anti-VEGF is still more the main line there. The Ozurdex, dexamethasone, is a higher dose steroid. Usually they last for 3 or 4 months. Sometimes you'll get a patient, you get them under control, and with one injection, they don't need another injection, or they might go longer. The fluocinolone implant, which is Iluvien, that's a much lower dose of steroid. And that is FDA approved for the treatment of diabetic macular edema, usually lasting for about an average of 3 years, sometimes shorter, sometimes longer. There is a similar implant that came out that's a fluocinolone implant that is used to treat uveitis and CME. We're not focusing on uveitic CME so much today, but there's one that is used to treat that one as well. So more recently added and FDA approved treatments, brolucizumab, or Beovu as it's known, is one of our newer treatments, but is a cautionary tale on why newer maybe isn't necessarily better. So it was approved in 2019. You can see on the slide here the different kind of molecule sizes. Bevacizumab is our generic anti-VEGF. You see how large of a fragment that is. It's essentially kind of a full antibody. The ranibizumab is a smaller, more targeted one. The aflibercept, we said, is the VEGF trap. Brolucizumab was meant to be kind of the single part without the other antibody Fab footprint. It's just kind of the anti-VEGF binding spot. So really, really, really small molecule, which was thought to clear out of the eye less, which led to more longer durability in a lot of the studies. Patients going 12 to 16 weeks between injections. After FDA approval, though, all of these drugs cause some inflammatory response. They're not native to the eye. And we talked about the fact that they're manufactured a bit as a biologic. So the body can kind of see this as something foreign. And so aflibercept, we see it at a low but somewhat decent amount, maybe around 1%. And the Beovu, we don't know probably the exact percentage. And Dr. Noble, you might know the number more, maybe roughly around 3 or 4% of those patients, 4%.
They did a retrospective just published last month. And sorry again for the unprofessional noises. Was trying to babysit this guy at the same time. So those fart noises were not part of the presentation there. So sorry about that, Matt. But they said 4.6% for post-injection inflammation, which was higher than the 1% that they initially quoted in the original study. And then there was 1% risk of moderate vision loss with when they did
some intraocular inflammation is expected with some of these injections. What was a surprise to us was pretty severe retinal vasculitis. So inflammation of the blood vessels, which was seen on fluorescein angiography, high rates of retinal artery occlusion and retinal vein occlusion. I don't have an image of it here, but number of patients got to hemorrhagic, essentially it looked like a horrifically hemorrhagic retinal vein occlusion with vasculitis, which in some cases led to, permanent blindness. And so we do have a few patients, I think, that are rarely on it, but we have to have a much longer conversation with patients about the risks of this drug, because it does last longer and it does seem to work better. You had a few patients who they had a great response to it, but we, took them off the medicine once we saw these side effects. You just have to have a very honest conversation with patients, and it's hard to get a patient who wants treatment when you would say to them, I'm going to basically be treating you with something that I wouldn't want treated in my own eye. If there were no other anti-VEGFs out here and this is the only one, and it was either this or, laser and blindness, then yeah, we would be using it, I think, pretty commonly. But when you have other agents that are out there that work really well, that risk benefit ratio does change some. So now on to some newer treatments that are really, really recent, hot off the press. The port delivery system with ranibizumab is called Susvimo. So it's from Genentech. And if our standard ranibizumab is 0.3 milligrams or 0.5 milligrams are injected in a 0.05 ml dose, this is a much higher concentration of ranibizumab. It's 100 milligrams per milliliter. It is a reservoir that gets surgically implanted into the eye in the sclera. Its indication is to get refilled at 6 months, but it can go longer. In a lot of the studies, patients were going a year or a year and a half between needing refills of the reservoir. So taking a patient who maybe needed an injection every month or 2 months and just needing an injection every 6 months or once a year is pretty appealing. In the study, it was non-inferior to getting ranibizumab every month. But the big issue here is that as a surgical device, you have some surgical risks and surgical complications. So when doing your conjunctiva and Tenon's fascia exposure, and I'll show you basically how this surgery kind of works a little bit. If there's any issues with conjunctival recession and you have a less than optimal conjunctival closure, then there's an increased risk of endophthalmitis with the implant at approximately 1.6 or 2% in the studies. Now, if we're looking at our anti-VEGF injections, for each injection, the risk of endophthalmitis is probably somewhere between 1 in 3,000 and 1 in 5,000. So this is a good deal higher than that. We're still kind of looking at, well, what's the risk and how is the best way to reduce the risk of endophthalmitis. So this is something that's starting to get done. In fact, Dr. Tilton did our first case a few weeks ago, or I'm sorry, actually earlier this week at our surgery center. And they're doing well, but this is something we'll have to look at. So this is the device. You can see it's kind of going into the eye, and you can actually see it on exam. And if you look up and you're looking in the sclera, you'll see where the little kind of footprint is. For patients or for our optometrists, I'm sorry, that have been around for a little while longer, you've maybe seen the Retisert and been familiar with the Retisert, a high-dose steroid implant that was used for typically more infectious uveitis or other indications. It's kind of similar to a Retisert. Once it goes in, it would stay in, and then you refill it with a very special needle that basically removes fluid at the same time that it's injecting a new dose of fluid. You put this in the OR, and then you're doing a refill exchange in the clinic. So you can see here, once again, just another image of how that looks at the implantation site. So there's a higher concentration in the implant. And there's passive diffusion across the end of it, where it's just passively being diffused into the eye where there's a lower concentration. The implant release is the rate limiting step of getting this into the eye. So here you can see a video of the surgery. It has been edited, but the conjunctiva has been removed, hemostasis. We have measured very specifically a 3.5 millimeter incision. We're making our incision, and in the studies, they found that you need to actually laser the choroid. So you're lasering the choroid and the blood vessel layer there because of the increased rate of vitreous hemorrhage that was seen. A small entry into the eye, and then placing the implant in and kind of getting it well seated, and then covering it up again with conjunctiva. I'll show that video one more time, just since videos are interesting and it's a cool video. Once again, so our scleral incision and cut down, our lasering of the bed of the choroid to reduce the risk of vitreous hemorrhage. We're using our keratome to actually enter into the vitreous. You can sometimes see a little vitreous prolapse there. And you might do a little vitrectomy from that prolapse vitreous and then pushing in the device. So then that is completed with a good covering of both Tenon's fascia and conjunctiva. And then here's a video of the refill in the clinic. You'll be able to see in that needle, right about here, you see that fluid that is kind of coming up into that little thing. So we are injecting the concentrated Lucentis, and at the same time, it's pulling out the residual Lucentis to make sure that you get a good complete fill of that fresh and highly concentrated dose of the Lucentis. So as we showed in the study, non-inferior to getting monthly ranibizumab in terms of keeping you at the same vision. Looking at the same amount of vision there. Once again, we talked about the surgical rates of things like vitreous hemorrhage and conjunctival erosion and retraction with endophthalmitis. The rate of vitreous hemorrhage was a little higher in the study, as well as a bleb, and this was mostly related to some of the patients that were being evaluated before lasering was done. There was a pause in the study in order to figure out how to reduce that rate of vitreous hemorrhage, and they determined and figured out that lasering the choroid greatly reduced that risk. So moving on to another new treatment from the same company, Genentech. If we've been talking a lot about anti-VEGF and the VEGF receptor 2 and VEGF-A as a target, there's the angiopoietin pathway, which helps maintain vascular stability under normal physiological conditions. So on this slide, you have two things. You have Ang1 and Ang2. So Ang1, it's produced by the pericytes, the cells that are sitting on the outside of the blood vessels, and Ang1 produced by platelets. And that is stabilizing the blood vessel and keeping the blood vessel intact. If we know about blood vessels in the body, capillaries and blood vessels throughout most of the body are meant to have both gas exchange, but also fluid exchange, blood vessel exchange, red blood cells, white blood cells, etc. You have the blood-brain barrier. You also have the blood-retinal barrier, and these blood vessels are meant to be tight without leakage of fluid. And so if you have enough Ang1, these blood vessels remain tight, they remain functional and working well. So tightening of these junctions, and then pericytes wrap around the mature vessels and result in maintenance of vascular stability and homeostasis. So Ang2 is kind of the opposite. You get vascular instability because you are blocking some of the Tie2 signaling. So you have both the VEGF receptor plus Tie2. And so when you have too much Ang2 over Ang1, then those blood vessels that are meant to be tight are leaky. So there's vascular leakage, increased inflammation due to the vascular leakage with leukocyte migration. And then you have the pericytes, so the support cells that drop out, and leading to even more downward signaling and progression. Then you're getting neovascular sprouting, and these immature blood vessels are leaky, which can cause vision loss. In several disease pathways, as you see here, the Ang1 levels remain pretty stable in the disease pathways, but in macular degeneration, retinal vein occlusion, diabetic retinopathy, the Ang2 levels go up to a statistically significant difference between your typical control patient. So as these Ang2 levels go up, they are driving disease growth. So this is Vabysmo. It is faricimab, which is a anti-Ang2 antibody in combination with anti-VEGF-A. So it's essentially a new drug called faricimab that is combined with something pretty similar to Lucentis. And so it's kind of a dual pathway target to treat the diseases. It is approved for both wet macular degeneration and diabetic retinopathy. And when we talk about the disease rates for intraocular inflammation, retinal vasculitis, et cetera, they took this, what we call the FC region, which is the one of the kind of antibody binding regions, and that was modified to reduce the amount of systemic exposure and reduce the inflammatory potential of this drug compared to other drugs. So what we see in some of these trials, the Yosemite and Rhine trial, were looking at patients, I believe this was for the diabetic pathways. And you can see that the majority of patients were able to be treated at Q12 weeks, which is 3 months, or Q16 weeks, which is 4 months. So 73% in the Yosemite trial and 71% in the Rhine trial. That breakdown is US patients versus worldwide patients, or what a lot of these studies are. So really taking a lot of these patients and being able to get them out at longer disease points in comparison to aflibercept in these studies. So rates of inflammation were low and comparable to our other drugs that we are using with. Some retinal artery vein occlusions, and these are seen with a lot of our treatments and a lot of our drugs, likely due to the potential underlying fact of these patients being older and being sick. And then these studies were, I believe, those looking at our macular degeneration patients. So seeing a large number of patients that were able to go out to 12 or 16 weeks with the faricimab molecule. So those are some of our new treatments that we have here. Here's our kind of upcoming and potential treatments that we'll talk about as well. So we will do a little plug at the fact that, as I mentioned earlier, last year we started the Advanced Vision Research Institute. This is our clinical trial side of the practice. So it started formally in 2021. We've been trying to get it off the ground for a little while. Mariah Fuller-Pazel was brought on last year. She is Coloradan, has kind of grown up in Colorado, was down in the Durango area and moved out to join us, and is a full-time clinical research coordinator. So she helps us with all these studies and has a lot of expertise. A lot of us are all working on a lot of these trials with the researches. We have an IRB to make sure that these studies are being well and ethically conducted, and that patients are being enrolled in these studies safely to reduce the risk of any adverse effects. We do have dedicated equipment to do clinical trials, and part of these studies include some new experimental imaging equipment that's not really on the market, and seeing what these can show us in terms of disease progression and a better understanding of what's happening. If you have any patients potentially for trials, you could reach out to us or Mariah. And patients and subjects are compensated for their time, oftentimes transportation is arranged so that the patient doesn't have to drive themselves or have a friend or family member drive them, and it does not cost them anything. So we have 4 current trials, and we'll kind of discuss some of these. Plus, I'll discuss some other upcoming treatments that are not sites for us, but looking at patients with wet AMD, or DME, or geographic atrophy. And very soon, probably in hopefully maybe the next month or so, the varenicline nasal spray that was recently FDA approved for the treatment of dry eye. The company Oyster Point Pharmaceuticals is looking at using this as a treatment for neurotrophic keratitis. So we're looking at being a site to evaluate if NK can be modified with the use of this spray. Plus, hopefully in the next few months, a trial on using gene therapy to treat wet AMD. Other avenues, of course, with clinical trials, glaucoma, cornea, and dry eye. So one of the ones that seems to be pretty exciting and interesting is the RGX-314 gene therapy. And this is a viral vector that's basically looked at for being used to get the eye to produce its own anti-VEGF. So basically having the eye make its own Avastin or Lucentis or whatever, that way you can take a patient and either get them completely off injections or greatly reduce the need for those injections. So there's kind of 2 avenues that they're looking at. One that is suprachoroidal, meaning that it's injected into the choroid space. And then the other one where you're putting in a small bleb surgically beneath the retina in order to get the eye to produce this. There are some diseases. So if we're talking about gene therapy, Luxturna is the main one that's out there. It was the first FDA approved gene therapy for the treatment of eye diseases, and it's targeting RPE65. So it's the viral vector for RPE65 being placed in the eye in order to get those eyes to produce the RPE65 issue there. That's usually treated in the macula, or typically treated in the macula. A lot of these are, we might be placing these kind of more in the periphery, so reduced risk of issues with that. So we're putting a little bleb there, and then the DNA is there to keep the, to make the drug be produced. First, going on to talk about complement inhibition and dry macular degeneration. And we've talked about the inflammatory nature of a lot of these diseases. They've been studied over the years since we don't have a lot of great treatments for advanced and geographic atrophy. So we looked at some inhibitors like C5, which didn't show a difference. So we've looked at other pathways which are a little bit higher up than C5. So either C3 or complement factor H or complement factor D, which are higher upstream targets that might work more effectively to reduce the inflammatory breakdown of the blood vessels, which leads to toxicity and damage of the RPE, the ellipsoid zone, and the photoreceptors. So the Alexion trial there's a few that are looking at injectable drugs, so complement 3 inhibitors being looked at for an intravitreal injection. I'll mention that with the injections in the trials, it looks as though complement inhibitors for geographic atrophy increase the risk of a patient going from dry to wet macular degeneration. So one of the downsides of this being that you might trade one issue for another, and now have to treat someone for wet macular degeneration because they seem to convert at a slightly higher rate for reasons that aren't fully understood. This is danacopin. It's an oral complement inhibitor, and oral is nice because no injections in the eyes. However, oral does also mean slightly higher risk for systemic side effects. Mostly immunosuppression is the main one of concern. So making sure patients are up to date on their vaccinations, aren't otherwise immunosuppressed, and making sure that they don't have liver issues since it's broken down in the liver. Unfortunately, with a lot of these trials, we look at who's a candidate, who's not a candidate. So these are looking at patients who have geographic atrophy, but not involving the fovea. So our ideal patients that we're looking for in studies like this are patients who have geographic atrophy where it's maybe involving the fovea in one eye, so they kind of understand what they've lost, and the other eye is still seeing well. Geographic atrophy is not involving the fovea, and we're using that eye as kind of the study eye to see if we can kind of keep the GA from creeping into the fovea and causing vision loss. If we talk about macular degeneration and the VEGF-A inhibitors, and you have the A and B inhibitors, then that's our mainstay of treatment. But you have a lot of patients who have resistance to therapy, or what we call tachyphylaxis. So over time, the therapies that we're using seem to be less and less effective. They'll work a little less over time. So what they've seen is that if you're suppressing VEGF-A, then you'll have an upregulation or an increase in VEGF-C and D, which also drive the same blood vessel disease. So looking at other anti-VEGF targets combined with a VEGF-A inhibitor, anti-VEGF, that might work synergistically to modify the disease. So if you see that Lucentis and then Eylea work on multiple receptors, VEGF receptor 3 remains untargeted and can lead to angiogenesis and blood vessel leakage as well. So we're looking at blocking that pathway in combination with that. UBX1325 is a experimental molecule that essentially is trying to induce apoptosis in cells. So if cells are under biological stress, then typically they're going to, a normal cell will usually have what we call apoptosis, meaning it will say, I've lived a good life, it's time for me to go away and die off and get broken down. Some of these cells that aren't functioning correctly are called senescent cells. They'll basically hang out and release cytokines, chemokines, other remodeling factors that are basically leading to disease growth and driving inflammation. So the thought is, if you administer one of these drugs that will specifically target those what we'll call senescent cells and gets them to undergo apoptosis and remove them, then you'll have a decrease in the VEGF-A and other inflammatory molecules and lead to less disease growth. So the UBX1325 is being looked at for both DME and AMD, and it inhibits the B cell lymphoma 2 pathway, or BCL2 family of apoptosis regulatory proteins. Another thing that's being looked at is if our standard dose of aflibercept is 2 milligrams, then a 4x concentration of aflibercept 8 milligrams, to see if that might work better and lead to either patients doing better at Q4 weeks or being able to go longer. So it's an exciting time, because as we are now, in the last couple of years, we've looked at, we've had our early on anti-VEGF, and we're coming into now what we'll call maybe more like the second generation, where we get great results, but we're looking at duration as our new goal. So not only having great outcomes for patients, but having it so that patients don't have to come see us as often. And as much as I love the patients that I see every month, because I get to know them so well, I think we're all happy to maybe not to have to see those patients as often. So I'll have this up here. I don't know if there are any questions. Carl, maybe you can see those to.
There
see if
weren't any
there are
other
any questions.
questions. I was just going to reiterate what you were saying. It's super exciting. All the new options we have. I will say it can be hard even for the retina providers to stay on top of everything that's coming down for new therapies. And it can be more difficult to discuss with patients and consent them for treatment because there's just so many options now. And I think it's going to be more of a tailored approach moving forward because every patient, some patients can get out to Q12 weeks with Avastin, and those patients are going to do great with Avastin. We just have a lot more options now, and it's fantastic, but it can be confusing, I think, for our referral doctors to kind of know how to best prep their patients if they do convert to wet macular degeneration. And then for us, just tailoring the approach for patients. But it's pretty awesome time to be providing eye care for wet macular degeneration.
Yes, thanks. Can everyone still see my slides? Is the QR code up for this right now?
It's not. I think it's just on. Well, maybe I don't see it.
Let me go back to sharing my screen. I think I had.
Yeah.
I think I thought I was sharing my screen and I'm not. So